So good morning, everybody, and we are back with our program right at 8 o'clock in the morning because a lot of people have to go a bit early. Hopefully, all of you had a good rest, and we'll have a quick sessions, very important sessions to start now. We'll be starting with the first session. Dr. Hemchand Prasad would be talking about two very important topics about growth hormone therapy and bone age. Dr. Hemchand Prasad is a very dynamic young pediatric endocrinologist from Chennai, and he has been involved in pediatric endocrinology for a long time and has been working untiringly in Chennai at Mehta Children's Hospital. Very dynamic teacher and very interesting way of teaching. So he'll be talking first about bone age, and then we'll have a talk by Dr. Yutika on PCOS management, and then again we will have the second talk on growth before the first session starts. So Dr. Hemchand, welcome. And I think this is his sixth visit to Kanpur, probably, if I remember correctly. So it's great that he has been spending time here with us and spreading knowledge. So Dr. Hemchand will start off with the bone age.
Very good morning to everybody. So let's have a small overview about bone age in the next 20 minutes or so. I would like to really thank the radiologists in our hospital who work with us in understanding bone age, which is an evolving aspect of pediatric endocrinology. So over the next 20 minutes, we will try to have focused questions and focused answers. The most important question: what does bone age tell a clinician? What is normal bone age? How to do bone age assessment and prediction of final height, how to plot it, when and how to interpret bone age, and where to be careful. So this is a simplistic understanding. Imagine a growing boy and various stages of his growth, and you see this boy having a growth velocity of 10 centimeters at 8 years, at 10 centimeters at 12 years, and 10 centimeters at 16 years. If your bone age is one parameter which is going to correlate with the actual biological age. For example, if you see a 16-year-old boy with a growth velocity of 16, you know that this is normal. But when you have an 8-year-old boy with a growth velocity of 10 centimeters, you know that he is biologically 14 and something is wrong. You need precocious puberty, you have to pick it up. This is a girl who is at various ages. You can see at 7.5 years, at 11.5 years, and 13 years with standard stage 2 breast. At 13 years, you're not worried because she's biologically only 12. At 11 years, you're not worried because she's biologically only 11. But when you see standard stage 2 at 7.5 years, you're worried because she's biologically 11. I think the first message with bone age tells us it is the actual biological age of the child, which correlates well with Tanner stage, menarche stage, growth velocity, muscle mass, and bone mineral mass. Life is a race. You are running, the child is running to reach the final height, which is acceptable to the population and for the family. A child who has advanced bone age has very little time to reach the destination. He can land up with early epiphyseal fusion and short stature. In contrast, a boy with a delayed bone age has adequate time. And as a clinician, if you identify what is the problem, you are able to help this child. So the second message which the bone age tells us is the growth potential of a given child. And this is a growth chart of a child. You see that the child is below the 3rd percentile, and the predicted height based on the growth chart is 145, which is less for the population and for the family. However, if you find that the bone age is significantly delayed, you know this is like a tortoise. He is growing slowly but steadily. It's a clinician's job to find out what is really causing this delayed bone age and find it out and rectify it so that he reaches the adequate growth potential. In the contrast, if you find that his bone age is advanced, he is running like a rabbit and going to land up as a dwarf. So the third important message the bone age tells us is what is the anticipated or predicted final height based on skeletal maturity. Skeletal maturation is dependent not only on hormones like growth hormone, thyroxine, and sex hormone, but also on nutritional factors, ethnicity, and sex. Hence, bone age has an important diagnostic value. A child with a delayed bone age, think in terms of poor nutrition, constitutional delay, growth hormone deficiency, hypothyroidism, and sex hormone deficiency. A child with an advanced bone age, think in terms of nutritional excesses, nutritional obesity, precocious puberty, and hyperthyroidism. So bone age as a clue to the diagnosis of the underlying disorder of growth. This is a child with tall stature. The chart on the left, you can see that the child is tall, but his bone age is advanced. So will ultimately land up at a height that is acceptable for the population. But if you see the growth chart of the tall child on the left, on the right side, you find that his bone age is almost same as his chronological age. He is going to land up as a giant. So I think the message from this is growth, bone age has important implications for a clinician to initiate therapy. So bone age helps the clinician take a decision on therapy of individual growth disorders. And lastly, it helps guide the direction of treatment. This is a child who was running like a rabbit, was having a significantly advanced bone age, was going to land up like a dwarf. The precocious puberty was treated with GnRH analogs, and the rabbit was converted to a tortoise. The bone age advancement was halted, the growth was accelerated, and the child is having an improvement in the predicted adult height. So bone age helps you to assess the response to treatment in growth disorders. To sum up, bone age is like the wife of every clinician who's treating growth disorders. It helps to assess actual biological age, the growth potential, prediction of final height, make a diagnostic decision, make a decision to initiate treatment, and make a decision to ascertain the response to treatment in growth disorders. So now, having understood the importance of bone age, what is normal bone age? This is very controversial. Literature says bone age is expected to lie within 10% of the chronological age. For practical purposes, any bone age within 2 standard deviations of the chronological age can be wait and watch, whereas a child who's having significant discrepancy away from the chronological age, more than 2 standard deviation, has to be looked into more carefully. This standard deviation is very less in infants and it's wide enough in older children. So bone age in a normal child is same as the chronological age. A mild delay or advance by around 1 to 2 years can be accepted as physiological variation. When you have a delay or advance beyond 1 to 2 years, look for a pathological cause. So we understood what bone age tells us. We understood what is normal bone age. So how to do a bone age assessment? And the first principle is to do a proper X-ray. I think the positioning of the hand, choosing the right hand, the non-dominant hand, usually the left, placed with the cassette facing down, and the forearm, wrist, and the arm are in the same plane, and fingers should not be too stretched, should not be too close. The thumb should be placed at 30 degrees angle with the palm, and the distance should be around 76 centimeters from the third metacarpal. So this would be something which you should put up in your radiology center so that the technicians are familiar and follow these necessary precautions so that you get a clear image for bone age interpretation. But remember, don't just look into the bone age, see what other clues it can give. Presence of any stipple epiphysis and hypothyroidism, any radiological changes of rickets, any short fourth or fifth metacarpal for diagnosis of Turner syndrome or hypoparathyroidism, growth error signs, also which an automated bone age assessment can miss, but a shrewd eye of a clinician can pick up, should also be looked for. So how to ascertain bone age? We have the APES method and the epiphyseal scoring method. So coming to the APES method. APES method is a very simple method of direct comparison. It is based on the principle that human visual system is fast at making comparisons. One assumes that the bones mature in a specific order with a specific set of sequences like growth, then development. Milestones, we expect any specific milestone at every particular age. Similarly, we expect every change in the radiological morphology with the growth of the child. So the APES method involves taking a proper X-ray, taking the page on the chronological age of the APES, matched for sex, deciding the points you will concentrate on, compare one ahead and one behind, one ahead and one behind, and assign the APES image which matches the most to the X-ray as a corresponding skeletal age. We'll see how it has to be done. And the first APES which is available is a dually confined APES. It has been constructed way back in 1931 to 1942 on 1,000 white individuals in the US. It was based on the principle of examination of each bone for maturity indicators. So the atlas was computed with 31 images for males and 27 images for females. Often one finds that fitting the image into a specific particular image of the atlas in entirety is difficult. But remember, it is a good alternative and it is something which has to be thought about. The second atlas, which has recently been available from 2001, is the Bisphosphonate and Repeat Atlas. It is constructed based on well-nourished children attending the Children's Hospital of Los Angeles. They took about 9 images for every age and sex, and the software generated idealized images which were supposed to represent the specific age and sex matched maturity indicators. So it was an automated tool, and this tool has been validated with the Blue Atlas in a separate data set. So what bones you should look for in infants? Please concentrate on the carpal bones and the radial epiphysis. In toddlers, please look into the long bones of the hands. In prepubertal children, look into the morphology of the long bones of the hand. In puberty, concentrate on the relationship between the epiphyses and the metaphyses of the long bones of the hand. And in post-puberty, look into the relationship between the radius and ulmus epiphysis and metaphyses. So these would be the specific bones one should concentrate at different ages. So we saw about the atlas methods of bone age assessment. The epiphyseal scoring method, which is a more accurate method, and it is generated based on data way back in 1930 in European children. It involves measurement of specific epiphyses and assessment of maturity based on a specific morphology of the epiphyses and score them from A to I. It is supposed to have a low inter and intra-observer variability. It is time consuming. Literature says the time to assess a bone age for the TW3 is about 70 minutes. It has been revised twice, and the TW3 is what is recommended to be used now. It includes the RUS radioulnar score, not only from European children, but also North American children and a little bit of Asian children. And every country has developed scores for its own population to improve the accuracy and precision of bone age assessment. So concentrate on the 13 bones, 13 epiphyses, the radius, ulna, metacarpus 1, 3, 5, proximal phalanx 1, 3, 5, middle phalanx 3 and 5, and distant phalanx 1, 3 and 5. Look at the epiphyses, compare it with the image and assign the score. Convert the verbal score into a numerical value, add the score, and compare and assign the bone age. Looks very complicated. Let us see how we are able to do it. Final height prediction. Final height prediction is the anticipation of the final height based on the current height and the skeletal maturity. TW3 method, it involves using the TW3 equations to calculate the final height. Atlas method, use the Rayleigh-Pinot tables to calculate the final height. So let us begin by looking into a small case. This is a 12-year-old child who comes to us with a height of 135 centimeters, weight is 30 kilograms. You see he is just close to the third percentile. The family is concerned about the future growth and final height. So a decision is made to do a bone age and final height prediction. So let us see what is done using the Tanner-Whitehouse method. So the Tanner-Whitehouse application is downloaded, free for download, Google Play Store. The sex is chosen. Specific epiphyses is looked into. The first epiphysis one looks for is a radial epiphysis. You start off with comparison of the epiphyses from A to I. Look at the morphology of the epiphysis. Look at the morphology on the cartoon and read up the literature. Go sequentially from A to I and see which image matches the most. As you can see here, it matches almost nearly close to the G alphabet. So like that, it is done for the second bone, ulna, the third bone, first metacarpal, the fourth bone, third metacarpal, the fifth bone, fifth metacarpal, proximal phalanx of the thumb, proximal phalanx of third finger, proximal phalanx of fifth finger, proximal middle phalanx of third finger, middle phalanx of fifth finger, distal phalanx of the thumb, distal phalanx of the third finger, the epiphysis, the morphology and the text are all matched. All of them are put together. The radial mass score is arrived at, and the bone age is arrived as 11.2 years. It's very simple. Look at the image, look at the cartoon, look at the text, and click the alphabet. You will all get it added up, and you'll see that the bone age is 11.2 years at a chronological age of 11 years. So let us see how to do it using the Grulich pile atlas. Take the Grulich pile atlas, match it. You see the child is 10 years. So you start off with one age below. Look at the image, look at the text, look at the image of the atlas. Read the literature meticulously, and you will find that this child is 11 years. The image is matching with the image of the child who has a skeletal maturity of 11 years and 6 months. So I hope it is clear. Look at this, just see, comparing. Look at the image on the X-ray, look at the image of the atlas, read up how the atlas guides you and arrive at the skeletal age. So the third method is a Gilson's and Rathi atlas. Again, the same principle. Take the chronological age, one age below, one age above. 8 years, 9 years, 10 years, 11 years, 12 years. You find that this matches the most with the sequentially you idealize images, and you find that this method, the assessment is 11 years. So what is it that we have done? We have calculated bone age using the Grulich pile, Tanner, Whitehouse, and Gilson's method. Now, if you calculate the Tanner predicted adult height using the TW3 method, it involves calculation based on the current age, current height, and radial mass score. Mathematical equations help you arrive at a predicted adult height of 162 centimeters. If you use the Grulich and pile atlas, this is very simple. The atlas has Bailey-Pinot tables at the back side. All you need to do is to see the height which is currently present on the y-axis and the skeletal age which is there on the x-axis. The point of intersection of the two, you would arrive at a predicted adult height. But remember, these are Americans, so they will give everything in inches. And Bailey-Pinot tables are available for children with normal skeletal maturity, advanced skeletal maturity, and delayed skeletal maturity. So for this child, you would probably choose something with a normal skeletal maturity. And this is the Gilson's and Rathi predicted adult height. You just have to see the height, the bone age, and the chronological age, and calculate it. It is arriving at a predicted adult height of 166. To sum it all up, a 12-year-old boy came with a current height of 135. They were concerned about the future height. Bone age was assessed using the TW3. The bone age came up to 11.2 years, and the predicted height was 162. This is computed using the app which can be downloaded from the Play Store. Grulich and pile atlas, bone age was 11.5 years, predicted height was 164. And it was procured from it can be procured from the Amazon. And Gilson's and Rathi, the bone age is 11 years. The predicted adult height is 166, which can be freely downloaded from the net. So using all the three methods, you are arriving at a predicted adult height above 160 centimeters, which is above the threshold to suggest any growth promoting therapy. So you can reassure and send this family home. I think, of course, there are pros and cons. TW3 is accurate, validated, updated, but time consuming. The Grulich pile atlas is time tested based on American population that has not been updated. Gilson's and Rathi, user-friendly, recent data, but you need more studies to validate this in the Indian population. And a word about automated bone age assessment. Bone expert from Denmark. It is done using the 13 RUO scoring method, a 3-layered approach which gives a bone age by automation using the Grulich pile as well as the TW3 method. The advantage is because it is done by automation, intra and inter-observer variability is minimal. It is quite accurate, quite precise, but the cons would be the cost. Indian data on bone age, a lot of studies have looked into the applicability of the various atlases and the automation as well as the Tanner-Whitehouse methods in different populations. This is our own study which showed that the TW3 method is the most accurate method for the Indian population. So how should it be plotted? We understood what does it tell us. We understood what is normal, what is abnormal, how to do it, and how should it be plotted. You plot it as a cross. The cross is marked at the point of intersection of the current height on the y-axis and the bone age on the x-axis. This is the child who is 10 years having a delayed bone age indicating preserved growth potential, and it is joined by a dotted line. So, last and the most important question, when should we order bone age and how to? If you see a short child, see whether the child has residual growth potential and has a mild normal variant, which is a delay of about 1 to 2 years, or a significant pathological cause where the bone age is very significantly delayed and has underlying disorder like growth hormone deficiency or hypothyroidism. A tall stature who has advanced bone age, you're happy about it because the child is going to land up within the normal for the population. A normal or a delayed bone age, you're very worried because you're going to push the child into becoming an adult. The child with early maturation, a marginal advancement in bone age can be wait and watched. A significant advancement in bone age tells us that this child is like a rabbit and going to land up as a dwarf. A child with a late maturation, you are worried if the child has a bone age that is not delayed. When you see that the child has a delayed bone age, you would probably presume that the slow maturation is acceptable for the biological age of the child. But if you have a normal bone age, you know that there is sex hormone deficiency. This child probably has hypogonadism. And a child with obesity and delayed bone age, one should think in terms of non-nutritional causes. So when should a pediatrician order bone age? Any child with a growth disorder, short stature, tall stature, early maturation, late maturation, obesity with short stature, and of course, decision about therapy and response to therapy. So this is a sum up. So whenever you have a growth disorder, please do a bone age assessment and see whether it is a rabbit or a tortoise. And where one should be careful about bone age assessment in children who are born with SGA, syndromic children, skeletal dysplasia, as well as CKD, which affects the epiphyseal morphology and bone maturation because of the disease per se, and your bone age assessment may not be very reliable. This is our own work with IIT Madras, where we are trying to develop a bone age atlas. We have collected the X-rays and we are automating it. Let us see what it was. Take-home pulse, bone age is the actual biological age. It tells the growth potential of the child, the predicted final height, the diagnosis of growth disorders, the decision to initiate therapy for growth disorders, and ascertain the response to treatment. It should be done in any child with any growth disorder, short stature, tall stature, obesity with short stature, early or delayed puberty. It is marked as a cross at the point of intersection of the height and the bone age. It can be done either by using the epiphyseal scoring method, which is a ganoretrously accurate method, or you can use it using the atlas method of Buick pile and Bisphosphonate technique. The more the discrepant from the actual chronological age, more careful one has to be. And be very careful in children who are born HDA, children with chronic kidney disease, and syndromic children. Just to highlight two cases, this is a 22-year-old child. One would presume that this child has completed growth and become an adult. This child actually had a bone age of only about 12 years. So the spectrum of cases that is seen in our country is very bizarre and interesting. And this is a child whose chronological age is 2 years and the bone age is actually 10 years by the Gulick and Pyle Atlas reported by the Adrenal. The child has lost 8.5 years of growth. Whatever you do, you give GnRH, GH, anything you do, you won't be able to mimic what God should have done for this child. Highlighting the importance of early assessment of the bone age and picking up growth disorders. Thank you very much.
Thanks a lot, Hemchand, for the wonderful presentation on bone age. It was really such a power-packed presentation overall, and this really covered the entirety of it. Just to highlight a point, we have found that high standard deviation score for bone age. So, of course, we talk about plotting, but if you talk about objective measures, if you compare CDGP versus a pathological cause, if your height SPS for PA is more than -2, -1.8, -1.5, that is CDGP. And if it is less than -2, it is likely to be a pathological. So that is the objective measure to look at. High standard deviation for bone age is what we can really get in terms of that. And all of you might have used our own bone age method. So we have tried to use to cut the number of sites, see how minimum sites can give a good outcome. So we found 5 sites to be effective radius, ulna, thumb, and 2 of these because we took 13, 10, 7, 5 and annualized versus 6 monthly images. So this makes the time around 1.5 to 2 minutes. And this has been validated against both own expert as well as standard White House. And it's on the process of publication. But wonderful. But I think the way forward is AI. Let's internationally huge publications are coming on automated. So one expert was way ahead of time, but now further AI will come in. But there are a lot of other issues, exposure, how much hand was spread or not, and the image capture. So it is a lot of mechanical obstacles for AI are there in terms of imaging. But it was a wonderful talk. Thank you, Hector. And that was a great talk. So I'll also now invite Dr. Dr. Aisha Ahmed, who is Associate Professor at Aligarh Muslim University in Aligarh, Department of Pediatrics, to kindly chair the session. Dr. Chetan Dave, he was there and he is now not there yet, so he'll come back. Dr. Neha, to chair the session, please. The next talk is on a very, very important and a controversial topic of polycystic ovarian syndrome management in adolescents. Now, we all know about the guidelines which are there with regards to the treatment in the adults, and there are a lot of confusion there as well. So what we are trying to look at is what should be the best way to manage in an adolescent girl, and that is a controversial topic because often by the time they come to us, the gynecologists have already started estrogen, progesterone, and other preparation. A lot of confusion happens in that perspective. And to address that, we have got Dr. Yutika, who has who is director of the Regency IVF, who has done fellowship in reproductive medicine from Melbourne IVF, as well as she also does the head of a pediatric adolescent gynecologist, which training she did under Royal Children's Hospital. So this is a nice intersection between pediatric endocrinology and gynecology. So we will love to have inputs of Dr. Yutika about how best to treat and when not to treat. Dr. Chetan, you can join as a chairperson there.
Thanks a lot, Dr. Anurag, for a kind introduction. And I'm very glad to be here amongst the pediatricians to talk about polycystic ovarian syndrome. Now, these girls, adolescent girls with PCOS, always fall into sort of a, they're sandwiched between the pediatrician and the adult gynecologist. And many times, things are actually missed and messed with their management. I believe that there has been a lot of discussion about the diagnosis and the criteria of PCOS. So I'm going to just focus my talk on the management aspect of PCOS. Basically, we all know the three criteria that the Rotterdam and the Endocrine Society mentions about PCOS, which is hyperandrogenism, chronic anovulation, which is persistent, and the polycystic ovarian appearance on the ultrasound, which probably is the most commonly diagnosed thing in young girls because it is very commonly mistaken. The large volume ovaries in adolescent girls, the multicystic appearance, and the fact that we are unable to do the transvaginal ultrasound for them. So very commonly a young girl, if she lands up with a radiologist for a lower abdominal scan, will be written polycystic ovarian morphology. So that is one contentious issue because very commonly that is found. So to call it as a polycystic ovarian disease or a syndrome, you need to have hyperandrogenism and chronic anovulation in this age group to say that this is PCOS, and it has to be unexplained. It has to be basically persistent. So any cause of temporary anovulation can lead to a polycystic ovarian appearance and hyperandrogenism temporarily. But if it is persistent, then only we label, and it has to be of ovarian origin. So all other causes of hyperandrogenism need to be ruled out before we say this is polycystic ovarian syndrome. Now, the problem with adolescent is that 12% of adolescent girls, due to puberty, hyperandrogenism, will have some clinical forms of hyperandrogenism, which could be hirsutism, could be acne. Plus, there is physiological chronic anovulation happening in the first 2 to 3 years of life due to immature hypothalamic pituitary axis. And due to that, you have irregular periods very commonly present in this age group. Plus, the standards are unclear when to start calling them PCOS, who are the patients we say that they are at risk, or who are the patients we know definitely will land up into PCOS later on in life. So the standards are very unclear. And about a third of patients, if you get a scan done, will have actual parameters of polycystic ovarian morphology. So when to say that these girls have actually a very high risk of landing up into PCOS or already have PCOS. So basically the North American Society of Pediatric and Adolescent Gynecologists have actually taken away the polycystic ovarian morphology from the whole equation totally and given a lot of importance to hyperandrogenism. So if you look at Rotterdam criteria, I don't know if you are aware of the adult criteria, there is the fourth type of PCOS where you have anovulation and polycystic ovarian morphology without hyperandrogenism. Those cases are not taken into account as PCOS in adolescent. So you need to have any clinical or biochemical hyperandrogenism to say that this patient has actual PCOS in adolescent age group. The testosterone cutoffs is 55 nanograms per deciliter for adolescent girls. Moderate to severe hirsutism. So hirsutism is a very subjective thing, and many girls might feel that they are hirsute, but it might not be actual hyperandrogenism. There is idiopathic hirsutism also present. So moderate to severe hirsutism, severe acne, not responding to treatment. The recommendation is that if they've been given vitamin A isotretinoin and yet they are persistently having acne, so those things are a significant hyperandrogenism symptoms. And age-specific irregular periods. So you might have irregular periods in the first 2 years of menarche. And normally they say that generally most of the patients have oligomenoric cycles, that is long cycles, infrequent cycles. And if there is a 90-day, say in the first 2 years, they are cycling longer than 90 days, then we say it is oligomenorrhea. The other aspect of anovulation is also heavy menstrual bleeding. So sometimes they have very frequent, prolonged periods. Even that is very significant in that age group because that is leading to actual problems. So it is an emergent aspect of anovulation. And plus, it has to be persistent. So a temporary 2 to 3 months period of irregularity will not be regarded as a chronic anovulation. And other causes, and I'm sure all those things have been discussed previously. So what are the goals of management of PCOS in a young girl? First thing is correction of hyperandrogenism. And we all know that even if it is a temporary cause of hyperandrogenism, permanent hirsutism develops because the vellus hairs, they convert into terminal hairs and it is very difficult to then revert them back. So if there is significant hyperandrogenism, especially in terms of hirsutism, that requires treatment for their current goals. Definitely menstrual irregularity. So there are two aspects of menstrual irregularity. You have patients who present with heavy menstrual bleeding. So that is an emergent aspect. You need to treat it because otherwise your patient is having a really poor quality of life and land up in anemia. But then there are patients who have scanty periods, which is oligomenoric cycles. In also those patients, because this is a chronic anovulatory situation, where a lot of estrogen is there without progesterone, this can lead to basically unopposed estrogen can lead to high risk for endometrial hyperplasia and even to endometrial cancer. So even a scanty period need to be treated if it is persistent, and that is why it is important to manage this menstrual irregularity in these young girls. And definitely we all know PCOS with their associated, and this is not my field, but metabolic syndrome has to be controlled, and obesity reduction, prevention of type 2 diabetes, and all those aspects are also important in the management of PCOS of young girls. The emergent things would be if you have severe hyperandrogenism, especially which is leading to almost clitoromegaly and all those things. So we need to rule out other causes of hyperandrogenism in these girls, and definitely this causes a lot of problems in the body image of those girls, and which can lead to even sexuality issues, self-esteem issues later on in life. So those having significant hirsutism, even with regular periods, needs to be addressed in this young girl, because it definitely hampers with her overall quality of life. The other, as I already said, menorrhagia is something that needs to be treated emergently. So even if the girl is not fitting into the complete diagnosis of PCOS, we need to treat her, because she will develop definitely anemia and has a poor quality of life. So I'll just summarize the pathophysiology in terms of how we treat it. So we all know PCOS is ovarian hyperandrogenism. The ovaries are tonically producing excess androgens. The majority androgen which is produced by ovary is androstenedione, which is peripherally converted into testosterone in the visceral adipose tissues, mainly the we say that the mesentery is the culprit here. So a lot of adiposity in the abdominal region can lead to conversion of androstenedione to testosterone, and the testosterone definitely causes insulin resistance to be higher, which is already present in obese girls and PCOS. 50% of PCOS girls have insulin resistance, which leads to decreased SHBG and higher free testosterone levels. So free testosterone is again converted into the active form, that BHT, which acts on the androgen receptors to lead to hyperandrogenism. So these are the various areas where we can work. We can decrease the ovarian androgen production. We can decrease the adiposity where the conversion is happening. We can actually attack the 5-alpha reductase to decrease the effect, conversion of testosterone to active form, or act on the receptor itself. So basically what we do when we use estrogen and progesterone combination, we are using the feedback loop of the GnRH to decrease the ovarian production of hyperandrogenism. So that's how we work when we are using the estrogen and progesterone combined pills, the contraceptive pills. So any pill, and the estrogen part of that pill actually increases the serum SHBG, so decreases the free testosterone levels. So it not only decreases the ovarian production of androgen, it also decreases the free testosterone levels. So effectively corrects the hyperandrogenism of these girls. Plus the estrogen and progesterone combination is basically providing a physiological estrogen and progesterone to prevent the chronic anovulation related effect on endometrial hyperplasia, regularizing the cycle. So these are the top medications that we use for the management of PCOS. The other aspect would be basically to actually, which is in adolescent girls, the major thing that is to work on the lifestyle. So if we decrease the adiposity in these girls, the conversion of even the physiological androgens that are being produced in this situation. So you have hyperandrogenism of puberty in these girls, especially in some girls, it takes a little longer time to mature. So a physiological situation which is leading to hyperandrogenism in combination with adiposity can actually trigger PCOS. So we can work at the level of prevention of true PCOS in these girls by managing the lifestyle, decreasing the weight, because then we are sort of an acquired sort of hyperandrogenism due to obesity is being corrected. So that is also very important. In some girls where there is very severe insulin resistance, especially obese girls with metabolic syndrome, acanthosis nigericans, addition of metformin gives you a synergistic effect along with both the estrogen, progesterone, and lifestyle to have a better effect, a better metabolic profile in these girls. And last but not the least, you have the GnRH analogs in girls who have severe hirsutism. It's very rare for some PCOS girls to have a frank, almost a high, what we call as ovarian hyperthecosis. There are very high level of androgens are being produced by the ovaries, and all the other methods don't work. Then you can have a complete shutdown of the ovarian function by adding GnRH analogs and correction of ovarian hyperandrogenism. Definitely, you basically how it works is by decreasing the LH and then causing a pseudo menopause kind of a situation. There are drugs that acts on the conversion of testosterone to DHT by attacking the converting enzyme, and then definitely it decreases the hyperandrogenism by decreasing the DHT. And last but not the least, you have certain anti-androgens present where you can use them for correction of hyperandrogenism, and we'll come to that later. Local measures, definitely, because already if the hirsutism is a prolonged, long standing, you have certain hairs which have already converted from villus to terminal hairs. Those definitely do not revert back, and you need to use local measures like epilation and laser therapy and all to have a complete cure of hyperandrogenism in these girls. And definitely coming to estrogen and progesterone treatment. Now, the first barrier for using this combination treatment in this young profile, generally I find, is because they are marketed as oral contraceptive pills, and usually these parents are, very scared of using pills in the young girls because of a psychological thing that they think. So I never call them pills when I am prescribing. I only call them estrogen and progesterone combination therapy. So when you use the right kind of explanation, they're more likely to take it. Otherwise, they just go out of the room and look for another doctor because they want to not use the quote unquote hormones in their girls. But you need to make them understand why these are important and what is the pathophysiology going on and why this can actually prevent development of a true PCOS in these girls. So mechanism we've already discussed. They decrease the androgen production by the ovaries, also decrease the DHEAS conversion, and definitely SHBG rises, so the free testosterone level is less. Effect is definitely you get a better periods, regular cycles, and also the hyperandrogenism is decreased almost by 30% in the FGS score. So definitely works. So any estrogen progesterone combination pill will work. You need not need to take a EP pill where the progesterone is anti-androgen, and I will come to it. The problem with these pills definitely is that role will correct the oligomenorrhea and hyperandrogenism, but the problem definitely will be high risk for, there are concerns for breast cancer, concerns for thromboembolic episodes, and we'll come to it. So it generally, most of the pills contain ethinyl estradiol as the estrogen component. The ethinyl estradiol dose in young girls definitely is what we recommend is at least for the bone mass is 30 micrograms. But some girls don't tolerate 30 micrograms. In those, you can use a lower dose, which is 20. The FOXY, which is the Gynae Society, the PCOS committee of FOXY recommends using 30 micrograms because 20 microgram dose basically decreases the estrogen levels to a level where bone accrual will not be optimum. So if majority of girls try to choose a 30 microgram dose when you are choosing the EP pills, only when you have, some hypertensives or where you have a CVS risk, where you can choose a lower dose. Some girls won't respond to 30. They have breakthrough bleedings, or sometimes their hirsutism doesn't correct. In those girls, you can use a higher preparation, especially if you have breakthrough bleeding. So a 50 microgram preparation is also available, which is the high dose pills. Higher dose means higher side effects and, long-term risks of thromboembolism and breast cancer will also be higher. So majority of cases, a 30 microgram combination pill is what we recommend. Adverse effect, we all know, these are the long terms, but 1 in 10 will also have a lot of nausea, a lot of, intolerant to the pill. But usually if you change the, the combinations, usually they're able to tolerate. With the pill, first few days, so first 15 days of treatment, they generally take a time to adjust to the nausea. And usually it goes away in majority of patients, but you can add a few things to cover that. For thromboembolism, it is generally present. The highest risk is present in the first year of use. If in the first year of use there has been no thromboembolism, then the risk is very less. For breast cancer in this age group, the risk is 13 per 100,000 women, which is quite low in terms of current users. And once you stop it, the effect goes down to 2. Okay. So the risk is not very high, and it is only for current users, because usually it doesn't cause breast cancer. It only basically picks up people who are genetically predisposed, they anyways would have gone into breast cancer. It is just like pregnancy. So pregnancy also picks up young women who had some needles of cancer in their breast, and just because they got pregnant, the pregnancy actually accelerates that cancer. It's the same effect. So once you stop using the oral contraceptive pill or the ENP pill, the risk is not very high. So it's not that if you've used it for 2 years in your adolescent age group, you're at a higher risk of breast cancer later on in life. It's not like that. It's only for the current users. So within those 2 years of use, the risk is higher. Once you stop, the risk goes away. So the other thing, initiation, definitely, if you have a patient who have a really, severe bleeding or very high hyperandrogenism, you use a higher dose estrogen for the first 3 months. And once the hyperandrogenism, you can, monitor by looking at the testosterone levels. When it goes down, you can come down to a lower dose, which is a 30 microgram dose. But you can start with the 30 microgram dose for all your moderate patients. Definitely, after initiation, we need to see what is the, generally our patients present with amenorrhea. So they've not had period for 2 to 3 months. So you need to give them a progesterone withdrawal and then start the ENP pill. And then follow them up to see whether there are any side effects. Usually the recommendation to use a 3-weekly regimen for majority of patients. There is a combination which is available in a 24/4 regime. But majority of pills available in the market, I'll come to them, are the 21-day therapy. So you give them for 21 days, 7 days off, 21 days, 7 days off. So 3-week on, 1 week off regimen is what is used in these girls. But definitely, if there are patients who have severe hyperandrogenism or menorrhagia, in those girls, you might probably use a very, a prolonged therapy, say a 3-month therapy, 7 days off, 3-month therapy, or 3 monthly periods that you can offer them. Sometimes patients present with menorrhagia. There you can give them high dose progesterone to arrest the menorrhagia, and then start the estrogen and progesterone combination therapy later on to control their periods, because estrogen and progesterone combination therapy in those doses will not stop the periods. So you need to give them progesterone in a dose of 10 to 20 milligrams for, say, about 20 days. The periods will stop, and then give a withdrawal bleeding, and then come down to estrogen and progesterone. For estrogen and progesterone to stop the bleeding, you have to give 2 to 3 tablets a day, which causes a lot of nausea. So it's very important to use progesterone to stop the bleeding, and then switch to estrogen and progesterone later on. For hyperandrogenism, as I said, sometimes, it doesn't work. So you have to use a continuous therapy. Progesterone, the main use of progesterone is that if you use estrogen alone, so as we saw, it's the estrogen which is causing the negative feedback, which is causing the, SHBG rise and hyperandrogenism correction. But if you use estrogen alone, then it causes endometrial hyperplasia. So you need to give progesterone to have a regular period. So progesterone is being given only for cycle management, endometrial regulation. It also causes a bit of LH inhibition. It causes the major side effects of the pills. Mainly patient feels that they are gaining weight, fluid retention, bloating, breast pain, cyclical nostalgia, and even acne, because a lot of progesterone have a testosterone effect. So effect on the androgen receptor. So that is why to choose the pill is also important, because the kind of progesterone that you are using, and all the first generation progesterone, which has LNG and norgestimate, those kind of pills actually also have a combined thrombotic risk along with estrogen. So they have a higher risk of developing DVT and stroke when you use those kind of pills. So we'll come to that, what kind of progesterone to use. Effect, we also know definitely in combination they will reduce. So the preparations that are available for progesterone, drospirenone is available, cyproterone. Now these two progesterones are also anti-androgens. They act on the androgen receptor and inhibit the effect of the testosterone. So those are available in combination therapy not available isolated in our country, but it's available in Europe. Norgestimate, not available in India. And this progesterone is androgenic. So to avoid, if you have a combination therapy with norgestimate, and then you have other progesterones, so you don't get them isolated. They are all present in a combination with estrogen and progesterone pills in the market. So the desogestrel, which is the third generation progesterone, which is commonly available in the third generation contraceptive pills, is less androgenic, and this one is what we will recommend to choose if you are unable to choose the drospirenone and cyproterone because of cost reasons. Coming on to the combination pills that are available in the market, you have the Diane, which contains 2 milligram of cyproterone. So this is also available in other products like Crimson, and there are Cartella, and there are many products, but this one was the initial. So it contains ethinyl estradiol in 35 micrograms. So it is a bit higher dose, and cyproterone, which is an anti-androgen as the progesterone. Yaz is a product which was marketed only for adolescent. This is a 24/4 preparation. It contains estrogen only 20 micrograms and drospirenone 3 milligrams. So this one is basically not recommended by Foxy in India, but it's available in the market because of its estrogen dose. Yasmin, Yamini, there are so many products available in this range with 30 micrograms of ethinyl estradiol and drospirenone. Now this one basically, because of its activity, mineralocorticoid activity, is a preferred drug because it also prevents mood swings and all those things that happen. So for the PMDD that happens, so it is one of the drug of choice because of having an anti-androgen. The only problem with this is the cost. So with Diane and Yasmin, the cost is high. For young girls who have period problems and only mild hirsutism, the drug of choice would be something with a desogestrel. So a 30 micrograms of ethinyl estradiol and desogestrel, which is a less androgenic progesterone. It's not anti-androgenic. The cost is great. And this one basically works wonderfully in majority of patients. It only, if this is not working, you can go to the higher progesterones because of the cost. But you can straight away begin with higher progesterone if there is significant hirsutism to have a better cure. Now we also have a cheaper version of ethinyl estradiol available, the overall L. The cost of therapy is only 60 to 80 rupees per month. But the problem with this combination is that it has got the first generation progesterone, the LNG, which basically is androgenic, and some women actually, if you give them, will develop acne and hirsutism increases. So you need to choose the right estrogen and progesterone combination to have a better result in your patient. So the effects, menstrual regularity becomes better. Hirsutism gets better only after 6 to 12 months because of the cycle. So the growth cycle of hairs, all the phases, it takes about 6 months. So what the drug is doing is preventing the growth of new hairs. It's not working on the already terminal hairs. So before the patient appreciates that there is something happening with the pill, is first thing is 6 months. So if you have a patient who has really high hyperandrogenism, the better way would be to do a testosterone level after 8 to 12 weeks to see whether the pill is working or not. Because clinical improvement in hirsutism will occur only after 6 months. So that you can do. Basically, menstrual regularity, within about a couple of months, you will see that the cycle becomes regular. And if it is still irregular, it is mainly adherence is not there, or sometimes the dose you need to increase because we are using 30, you might go to 35 or 50 micrograms to see if the adherence is not a problem. As I said, when you are doing the test for testosterone, estrogen and progesterone pill is actually a better test would be to do a free testosterone. So better effect is happening via the SHBG. So it is increasing the SHBG, and the free testosterone level is going down more than the total testosterone. So it's important to do a free testosterone level and monitoring in that manner. The duration of therapy, and that is very important and very commonly asked questions, because these girls are chronic anovulation until the time they develop hypothalamic pituitary maturity. We cannot say whether this is the adolescents, the age group that is causing the problem, or whether it is the hyperandrogenism. So we need to complete the therapy till gynecological maturity, and which is now recommended because of the lifestyle changes that the adolescent have had. We used to say that within 2 years, the hypothalamic pituitary axis matures, and majority of women will develop ovulatory cycles after menarche, 2 years after menarche. But now the recommendation is 5 years after menarche, because generally most adolescent girls, the lifestyle is really poor. They are in that age group where they are, sitting and studying for their boards, and it's really a messy time for them. So usually taking a longer time to mature. So we generally recommend treatment for at least reaching up to the maturity whenever you are starting the therapy. So say 5 years after menarche. So basically, weight loss is another thing. So if your patient is able to achieve at least 10% of weight loss and has a better lifestyle, you can stop and see. So if you are achieving that lifestyle goals, then you can stop and see what's going on with their cycles. And about patients who are at a higher risk of developing PCOS. So when you are in this age group, we generally don't give a label of PCOS to them, because 50% of these patients can grow out of it with weight loss and a better lifestyle. True PCOS patients are generally who have some high risk factors. So you have a family history of PCOS, family history of type 2 diabetes, low birth weight baby who they had premature puberty, or some sort of features of insulin resistance, and those things happening. Those patients are more likely to be true PCOS and will not grow out of it. But there are other groups with mild hirsutism, only period irregularity, no high risk factors, and they're able to lose their weight. Those are the girls who will grow out of it. So very important to identify these patients and keep counseling them, because true PCOS patients will revert back to PCOS once you stop the estrogen and progesterone therapy. Their periods will still become irregular and start having hirsutism and all those things again. So we need to identify who are the patients where we'll be doing. But there is no role of doing the ultrasound again and again, because once you are giving estrogen and progesterone pills, after say 6 months, if you get the scan done, the ovarian size will decrease, because the chronic anovulatory picture has gone, is away. So the ovarian antral follicles number will go down and the PCOS will look corrected. But once you stop, again the whole thing will come back. So there is no role of using ultrasound to tell them that your PCOS is getting corrected. It's more important to tell them that we cannot say that you have PCOS, but you are at a very high risk of developing PCOS when you grow adult. Very important to correct your lifestyle, have a better weight profile, better lifestyle profile in terms of exercise and all those things. Then only you can grow out of it. So we need to differentiate chronic anovulation due to immature hypothalamic pituitary axis from a true PCOS girls. So that is the most difficult part in the management of young girls. And the other thing is also correct. Any chronic anovulation for a very prolonged period of time, maybe so this girl was not destined to develop PCOS because she had no high risk factors to begin with, but she became very obese during adolescent age group, definitely she will develop PCOS. So prevention and treatment both are happening at the same time, because a very elevated a testosterone actually switches the negative feedback arm to a higher LH profile, which is, I am sure you probably have discussed all those things in your previous discussions. So it becomes, so even if, example that I give is that a girl who was not genetically destined to develop into PCOS, if she is growing in a mother's womb who has hyperandrogenism, will develop PCOS because of hyperandrogenic exposure to her pituitary and a higher gonadostat. So that's why in this period of time, treatment also prevents development of PCOS. That is important. And that kind of counseling needs to be given to these girls very importantly. Follow-up is only for adherence and to see what things are happening. I generally call my patients after 15 days to look for the acute side effects of nausea, vomiting, tolerability, breakthrough bleeding, and then 3 months after, and then 6 months till till the maturity period. Keep counseling. If it was mild, we can stop and see also. Definitely what we have to look for is the blood pressure. About 10% will develop hypertension after initiating therapy, and also look for their things. Progesterone only pill. Sometimes, you know, the mothers are very, very scared of using estrogen combination pills. So if you have a patient who have menorrhagia, then at least we can manage their periods by using these pills. And definitely the indication is when there is no hyperandrogenism, and there is contraindication to ENP because of, you know, the only contraindication for estrogen progesterone pill is cardiovascular disease, hypertension, and personal history of breast cancer. Even if there is a family history of breast cancer, you can use it. It's not a very high risk of developing breast cancer. But if you have a personal history of stroke, of DVTs, of family history of DVTs, those are the patients where you have to be a bit cautious. So you can use the only progesterone pill in those patients. Medroxyprogesterone 10 milligrams. You have got sustained release preparations available also for these products. And you can use micronized progesterone. Generally recommended to use, the effect will be definitely they will stop the period as soon as you use them. But if you stop them, then the period will start again. So it has to be given, say, cyclically, so that you have a regular sort of withdrawal bleedings. No effect of hyperandrogenism of progesterone in that doses. Minimum for prevention of endometrial hyperplasia, you need to give 10 to 14 days every month, so to prevent endometrial hyperplasia. So if you have a patient who has oligomenorrhea and you want to use progesterone just to give her regular cycles, you need to use it for at least 10 days every month so that they have regular withdrawal bleeding. But if you have a patient with menorrhagia and you have to use it for cycle control, you will use it for, say, from day 5 to day 25, 20 days every month to have a better thin endometrium and a better period. They don't have any cardiovascular risk. So this one is the most kindest progesterone. So the progesterones that we are using for period control is medroxyprogesterone, no cardiovascular risk, but they have a lot of fluid retention, so cyclical mastalgia, pain, and those kind of things. So GnRH analog, I will just quickly go through. This is only for who have really refractory hyperandrogenism. Say about only 1% of patients of PCOS we use it when nothing is working. It's the same drug that you use 4 weekly, maybe decapeptyl or leuprolide, even 3 monthly doses. Effect is it shuts down the ovaries, no ovarian production of testosterone, hyperandrogenism is corrected, but it also causes amenorrhea because estrogen is not being produced. So you need to give add back estrogen after 6 months of therapy, otherwise there is a problem with the bones. Again, you will have to add estrogen and progesterone after 6 months of GnRH. So very rarely used in PCOS, only for ovarian hypertrichosis patients. Again, lifestyle is the main treatment. This one is going to get them off the pill. So this is the main treatment that needs to be given. Nutritional therapy with regular meals. So for adolescent girls, we don't recommend a lot of, you know, keto dieting and starvation diets and those kinds of things because of their bone and the growth potential that they have. But definitely losing about 10% of their adiposity definitely starts their ovulatory function. And, you know, definitely all those things, you know, I really don't want to go into that. Metformin only indication if there is features of metabolic syndrome and features of insulin resistance. Definitely those you all know, but the combination of metformin and estrogen and progesterone also works better, makes them, you know, help in lose weight, and it definitely has some role in adult women where we are using metformin for causing ovulation and correction of fertility. But in this age group, only in patients where you are thinking at a high risk of type 2 diabetes and insulin resistance, only in that cases you will use it, because it definitely has no effect on hyperandrogenism and correction of acne or hirsutism, very minimal effect. So on using metformin isolated for hyperandrogenism correction will not be a great idea. So coming on to basically bariatric surgery, again, I think you guys have all discussed these things only for extreme cases where they have complications, where you want to prevent development of diabetes and severe obesity. Anything which will cause weight loss will correct their chronic anovulation, correct their hyperandrogenism. So definitely obesity related androgenism and hirsutism all gets corrected. But again, in this age group, only for very, very rare cases. So that was the holistic management of PCOS. Now again, some people will not respond to that therapy. So you need to add few other things to decrease testosterone. We can do with estrogen and progesterone by decreasing. But whatever is testosterone is there, if some people are highly sensitive, you can decrease the conversion by attacking the 5-alpha reductase hormone, conversion to DHT by using finasteride, and then spironolactone, aldactone for attacking on the androgen receptor and correction. Cyproterone, androspirinone, as I already said, also act as anti-androgens. Flutamide is a very mild version of androgen inhibition. Even that works in certain cases that you can use. Aldactone is the most commonly used drug, spironolactone, for people who have not responded to estrogen and progesterone therapy after 6 months. You can add this. But with this, if you're using it alone, it causes irregular period, development of ovarian cysts. So in this age group already, where there is a problem of irregular age group, we do not recommend using aldactone alone for the correction of hirsutism. Always combine it with estrogen and progesterone pill. Plus, this age group, this is a teratogenic drug. So if somebody is sexually active, planning pregnancy, it will cause ambiguous genitalia in a male fetus. So that's why combining with a contraceptive pill will also be a good idea. So prevention of cyst development, regular cycles, that would be additional. But if you're giving it alone, then you have to at least give them progesterone to have a better cyclical profile. Start with 25 milligram dose, maximum dose is 100 to 200 milligrams per day. What you need to monitor in them, they can develop postural hypotension, and they can also develop electrolyte imbalances and liver dysfunction that you all know. Again, any effect on hairs will take a latency period of 6 to 12 months before you start saying that it's not working. Wait for at least 6 months, and then you can add ENP for a combination therapy, which will have a better effect. Finasteride, again, the same, it basically is a 5-alpha reductase inhibitor, and you can give it isolated, but you can give it as a combination therapy. The dose is 5 milligram. The effect is only mild. So only in mild cases where your patient are not ready to take estrogen progesterone pill, you can choose this drug, but it will not have a great effect on other things. Local measures, as I said, will be needed for people who have severe hirsutism, because complete correction of hirsutism is not possible with hormone therapy alone. So you will have to use these methods for a complete cure of hirsutism. So just to summarize, estrogen and progesterone will work on your hyperandrogenism, will work on the period problem, and has no effect on the insulin aspect, where you have to combine it with lifestyle or metformin. Progesterone will only work on the period, no effect on hirsutism or the insulin resistance. Anti-androgen will actually worsen your period problems. So you have to combine, if you have both anovulation and hirsutism, you have to combine it and then give, no effect on insulin resistance. Metformin, if you have a patient obese, high risk for metabolic syndrome, then combine it, but it will have no effect on hirsutism or some effect on menstrual irregularity by decreasing weight and causing ovulation. GnRH analog rarely used, only for severe cases to shut down the ovaries. And just to summarize the PCOS, you have to definitely say whether this is a very high risk case of PCOS, definite PCOS, then you have to definitely start treatment. Look at lifestyle, metformin if there is a high risk for metabolic syndrome, estrogen, progesterone, clinical response in 6 months. And basically, if it is only mild hirsutism, where you think that patient is just maybe going into PCOS or maybe hyperandrogenism, you need to reassure them that this is only hyperandrogenism of puberty, but there are high risk factors like menorrhagia or severe hirsutism or severe acne, or high risk factors like that this patient was a low birth weight baby, premature puberty, then you need to start treatment for them. And treatment is same till gynecological maturity. Counsel them to lose weight because 50% will grow out of them. But if the symptoms return, then they have to be treated by adult people. Additional anti-androgens can be added if the basic treatment is not working. Thank you.
I think this was a very covering every aspect of hyperandrogenism. Comments from Dr. Ayesha.
Nice presentation, and you have explained such a complex and often debatable topic in such a nice manner. But I believe that managing a child, a person, especially adolescent with PCOS, is as difficult as diagnosing, especially with the current rise in the incidence of obesity. So it becomes more difficult. More adolescents with obesity, they are falsely labeled as PCOS. So what I just wanted to know, based on your experience with the total number of diagnosed cases of PCOS, so how many of them had, like, they were born low birth weight or SGO? How common is that?
Not very common in the clinical practice, but I think patients who are going to endocrinologists more, they have a lot of low birth weight babies. In our cases, we get more of menstrual irregularity patients. They are less true PCOS. So the majority of walk-in patients that I see are patients with hyperandrogenism due to their lifestyle, and they grow out of it. Only the true PCOS patients who eventually they are leaner, they have more adiposity. They are not like true obese. They have tummy is protruding, and those kinds of patients, they have more of low birth weight history. They have history of premature puberty also. So those are the patients that I really think that they will not get out of it, and they will go and become true PCOS. Yes. Generally, we recommend treatment for patients. Suppose you have a patient with irregular periods and hyperandrogenism, 14-year-old, 2 years of menarche, and she has these high risk factors, then definite treatment should be given, because whatever chronic hyperandrogenism due to anovulation will also lead to development of PCOS. And the time limit is generally we recommend at least 5 years post menarche. So 2 to 3 years of treatment is generally recommended for them. And if they have lost weight, then many of them don't require treatment and they grow out of it. But whenever they gain weight, they get back to the same situation. But if they have not lost weight, they stuck there. You have to, keep using it. Only for mild cases, in the first year itself, we stop and see to, identify those cases who have just hyperandrogenism of puberty. So they are not true PCOS. And then you give 6 months of therapy and their periods are better. So those are the cases that I see most commonly, and they are most commonly misdiagnosed as PCOS. Yeah.
What type of hormone will
Sorry?
Thromboembolic.
No, I have not. In India, I think very, very few cases. All these studies are from Western literature, because they have a higher incidence of factor V lead-in mutation. So in UK and Western European patients, I have not seen not even a single case of current users developing DVT or anything in my practice. But definitely there are patients, there are some reports.
Stroke is the most commonly reported one. Stroke will be a common one.
Yeah.
Now I have a question.
I think-
Thank you for the very insightful talk. If time permits, just a small question.
Yeah, we'll have just last question, because this
Are there
question.
any differences in the management, or is there any complication that we face in the management of mean PCOS? Like, is there any role of myoinositol and metformin in cases of mean PCOS?
Definitely, lean PCOS patients are completely two different category of patients. There are some lean PCOS patients who have some adiposity, visceral obesity, and then there is a what we call PCOS type 4. These are those genetic anovulatory patients who have only ovarian hyperandrogenism. They don't have clinical features of hyperandrogenism, so they only present with menstrual irregularity. They have no features of their testosterone levels are normal. So what we call PCOS type 4. These patients will develop infertility later on, but they don't have metabolic syndrome and high risk for those factors. So treatment of both the cases is warranted. For type 4 PCOS in adolescent age group, if they have very infrequent periods, then the chronic anovulation is leading to endometrial hyperplasia. So only for the menstrual correction. It is these patients where you can give only progesterone also. Okay. And the other lean PCOS, which have insulin resistance with them. So you need to identify whether they have those metabolic profile happening. So they are lean, they have a bit of adiposity, and but they are developing hyperandrogenic features. Those are the high risk patients. Actually, these patients will develop a lot of complications, even type 2 diabetes, all the metabolic syndromes. So those need to be treated with both estrogen and progesterone along with metformin to correct all the three aspects of their care. So the periods, the myoinositol basically is sort of ubiquitous drug available, everybody is prescribing. There are no studies available, large scale studies. There are some few studies showing that it decreases hyperandrogenism. Good studies are there in IVF patients when we use myoinositol. The oocyte quality, embryo quality is better. So in adult patients, we are using it routinely. For adolescent patients, very few studies isolated myoinositol is correcting their hyperandrogenism. I think they are those patients, as I said, the mild cases of puberty hyperandrogenism. They are not true PCOS. I generally don't use it in a patient which is high risk, has chronic anovulation. So isolated use of myoinositol, no role in adolescent girls yet, but we don't know what it comes out. The studies are happening.
I think we'll just close on this last question from Dr. Satyakala from Melbourne. She's asking management of primary amenorrhea in PCOS, whether you will give E plus P or just progesterone. So presenting with primary amenorrhea, we do see some cases.
Yeah, definitely. Primary amenorrhea or oligomenorrhea, it is one of the same spectrum. Now, this is just a rare patient who has never had a period, but she is chronic anovulatory, and if she has hyperandrogenism, then you will have to give both E and P. And if she is just primary amenorrhea without any features of hyperandrogenism, she is probably the PCOS type C or type D, where there is only genetic chronic anovulation without any insulin resistance. Then you can use progesterone also. But the first priority is to give them estrogen, because this is a time where they need estrogen for their bone accuracy. So I would be in my 95% patients, I would try to push for estrogen and progesterone because they are the safest drugs. Only for those patients who have high risk for cardiovascular, high risk or hypertensive, or where the parents are not ready, only in those cases I will go for progesterone.
So just withdrawal and then you start with estrogen progesterone. Thanks, Dr. Yutika, for a wonderful discussion. And we'll carry forward with our session with the next talk, and that's going to be the last one, this one. That is on growth hormone therapy by, again, Dr. Hemchand. And we have been mesmerized by his presentations. So Dr. Hemchand, carry forward from there.
Morning again. So I think over the next 15 to 20 minutes, we will try to have a focused question. I think this session is kind of a literature review on what is new currently and what can be anticipated in the days to come. So what is new as far as anthropometry and growth charts are concerned? What is new as far as investigations pertaining to growth hormone deficiency is concerned? What is new pertaining to GH therapy? What is new about the long-term follow-up? What is new in the management of ISS? And what is new about the addition of GnRH analogs to growth hormone therapy? So I think all of us know very well about this new pediatrician-friendly growth charts, which have been constructed and released by the Indian Academy of Pediatrics, which obviates the need for mid-parental height calculation. This makes it very easy for clinicians, practitioners to bypass the step of calculation of mid-parental height and going for assessment of the discrepancy between the target height and the individual percentile height. And very beautifully, the third percentile for height has been marked as red. This is the new BMI lookup tool again from the Indian Academy of Pediatrics, which assesses us, which allows us practitioners to bypass the step of body mass index calculation. I think IAP is doing everything possible to sensitize and facilitate pediatricians to calculate mid-parental height, to calculate BMI, at least plot. I think that is the right. I think nowhere in country you can get this sort of an easy way of assessment of growth. This is useful in children above 8 years of age. This is the new extended growth charts for Indian children, which helps in growth clinics where you have children who are born SG and being followed up, and to pick up children with ISS, and to pick up children with pathological short stature. There is the -3 SP. So you have 3 additional percentile lines. One, to facilitate identification of SGAs who don't catch up. Number 2, to identify children with ISS at the cutoff of -2.25. And number 3, to identify children with pathological stunting, that is the -3 SPs. So this is very useful in growth clinics as well as NICU follow-up clinics. So new growth velocity charts are currently available. You have 2 sets which have been recently come up with in the past couple of years. One is from the group from Western India, and one is from a group in Northern India, published in IJEM and Indian Pediatrics. Which is better? I think other 2 are small data sets. Which is better out of the 2? I think that cannot be answered without prospective long-term studies, but I think both of them are indeed very useful, and it is up to clinicians to start using them. The strength of the data from the Western set would include that it has a long duration of follow-up. Z scores can be calculated and accounts for the secular trend. Peak height velocity approach has been taken. But it will be difficult to assess growth velocity of individuals less than 5 years, which is important in clinical practice. Whereas the group from the Northern India, you are able to do growth velocity calculation from 3 years of age, but the duration of follow-up is short, and significant attrition has been there in the group where SMR has been done and SMR has not been done. These are the new Indian growth velocity charts from Western India, very useful, published in Indian Pediatrics. Please use them when you're seeing chronic children with growth disorders, and use the 25th percentile to look into them more carefully. These are the new guidelines pertaining to growth hormones, specifically looking at the 2016 guidelines from the Pediatric Endocrine Society, and the GHRS guidelines from 2019. The key aspects of both the guidelines. What is really interesting to see is that the GHRS workshop had an Indian representation, and it kind of complements each other. The focus of the GHRS guidelines is on diagnosis and assessment. The PES guideline focus on diagnosis, follow-up, and therapy. So they kind of dwell well with each other, and they give us very beautiful guidelines, which will be the focus of the subsequent slides. Regarding oxology, the important difference as far as the previous guidelines and the current guidelines is the new guidelines are very aggressive in terms of oxology, in the sense that previously we used to wait till a standard deviation score of -3, but now they say even at -2, you look into them more carefully, not aggressively go and do all kinds of tests, but look into them more carefully, and a decline in Z scores. I think the anthropometry has shifted from percentiles to Z scores for specialists using managing growth disorders. Previously, a decline in height SPS was considered significant if it was a dip of -0.5. Now they have said that you start intervening even when the dip is -0.3. The idea is probably to facilitate pick up children with growth disorders early, and probably not missing grave conditions like a craniopharyngioma, which can present it just short stature. So the message is, if you find a decline in height Z scores -0.3, be careful about such a child. So we saw what was new pertaining to anthropometry and growth charts. Second, what is new regarding investigations of growth hormone therapy. The 2019 guidelines have added a couple of things in the sense that be careful. Don't just rely on oxology in children with familial short stature, cancer survivors, and they recommended the use of sitting height by height ratio over upper segment, lower segment ratio. And if you have a specific phenotypic features of shocks or FGFR3, going for a genetic test early. Regarding screening, I think a very logical shift to usage of bone age in children above 2 years has been made in the New Year guidelines. And complementary to the previous ones, they say less than 3 years, we do a combination of IGF and IGF-BP3. About 3 years, use IGF-1. And remember, they have rightly pointed out that obesity can fool us in children who have a recent onset of growth hormone deficiency and obesity. And screening tests, especially the IGF and bone age, can fool us in children with significant central pathologies like craniopharyngioma and hypothalamic obesity. So if the index of suspicion is high, please go in for the confirmatory step despite the screening test being normal. And a very, very important concept they have mentioned is IGF should be interpreted as sex scores and not as just the absolute values or looking at normal values mentioned in the specific lab report. And IGF value below 0, that is below the 50th percentile, be careful, not just jump and make a diagnosis of GST, but at least alert yourself and keep this child on a meticulous follow-up. Regarding growth hormone stimulation test, I think a lot of positive changes. I think the guidelines are shifting away from growth hormone stimulation tests and relying more on radiological features as a surrogate of growth hormone stimulation test. The VS guideline says if the oxological criteria are present and the MRI abnormality is present with one anterior pituitary hormone deficiency, a growth hormone stimulation may not be warranted. The newer guidelines have again gone one step further and said that when the index of suspicion is high, having a good oxological criteria, a very low IGF with a significantly delayed maturity, one test may be sufficient. I think it's a big positive step away in the direction of growth hormone stimulation test. And the cutoff using the newer assays in the GHRS 2019 guidelines is 7 nanograms per ml. So I think these are some of the important takeaways for us practitioners dealing with growth disorders. That one test may be sufficient in specific cases. Growth hormone stimulation test may not be needed in multiple situations, and the cutoff has been is as recommended in this slide. A new growth hormone stimulant currently not available in India, but probably maybe in the pipeline. Peptide mimetic growth hormone secretor drug, Masimorelin. It is the advantage of this is it is I think multiple companies are making, including Novo Nordisk. The dose recommendation is 0.5 mg per kg and oral preparation. And the advantage of this is the number of samples are lower and the peak is supposed to occur between 30 to 90 minutes. So the number of samples required is lower. So there are some adult studies which have validated the utility of this diagnostic tool in adult population. Childhood data is yet to come, but I think this may be in the pipeline in the days to come. So an important takeaways include that tests have to be done fasting after supplementation of other hormones. And there are a number of situations, routine GH stimulation tests may not be needed, especially in syndromic children like Turner syndrome. We have dogmatically mentioned Prader-Willi syndrome, Noonan syndrome, where you know the underlying pathology and the oxological criteria are satisfied. I think you can bypass this step, and that's a big relief for the patient also. And a very, very important statement, you have to integrate all available data, clinical, radiological, oxological, biochemical parameters. It's like a jigsaw puzzle that everything has to be fitted in and a diagnosis of growth hormone deficiency has to be made. Regarding a very, very important message for practitioners is regarding genetic testing. So you have specific indications where you have to go in for genetic testing. They have very beautifully defined what is exome sequencing, what is whole exome, whole genome, etc. And they have kind of given this one, and probably in the subsequent guidelines, the focus will be more on genetic tests. If you have these particular criteria, phenotypic of a specific syndrome, history without catch up with very significant growth deficiency, I think probably genetic test comes first in the pipeline, not later on. The last but most important test evaluation of growth hormone deficiency is the MRI brain. The 2019 as well as the previous guidelines have given a very strong pitch to look into MRI, which can probably considered as a surrogate of a second growth hormone stimulation test. Not only look at tumors and defects, if there is an MRI abnormalities in the form of a specific triad, then add another pituitary hormone defect, you can obviate the need for a growth hormone stimulation test. And many a time we encounter this report as hypoplastic pituitary. The guidelines have taken that into account and said that that cannot be taken as a single point for us to make a therapeutic decision about growth hormone deficiency. But of course, that really helps us also in making a diagnosis of GH deficiency. The MRA, it has other utilities as well. It helps us predict pituitary hormone defects, as discussed extensively during the grand rounds. The enlarged pituitary, hypoplastic pituitary, and etc. gives important clues about the underlying defect as well as the possible associated pituitary hormone defects. It also gives us important clues about the identification of the intracranial space of lesions and of course, identification of anatomical defects and other CNS disorders. A recent development has been the availability of the pituitary normative data for Indian children. You have growing children's pituitary height and pituitary volume has been presented for our clinical use. Probably when we get pituitary volumes and pituitary heights, we can use this data set to compute these scores and probably see whether it is hypoplastic or not. Conventionally considered height below 3 millimeters as hypoplastic pituitary, but I think with the normative data, it may be useful for us. As discussed previously, the new guidelines have said in a neonate, oxalogical criteria need not be satisfied because you know about the ICP model, where GH plays a very minimal role in the oxalogy as far as the neonates are concerned. A value below 7 nanogram per ml with a high pretest probability, as in the case yesterday where we saw a child with septo-optic dysplasia with all the features satisfied. Growth hormone levels below 7 nanograms per ml should be considered as consistent with growth hormone deficiency. The most controversial and most but yet I think probably a very useful tool is priming. Priming is a tool which helps increase the specificity without compromising the sensitivity. You avoid false positives. I think the guidelines kind of complement each other, how to prime and when to prime. All adolescents with delayed puberty and prepubertal boys above 11 or 10 years should definitely be primed. And how to guide do the priming has also been very beautifully mentioned in the guidelines. I think so. I think we should just have to adopt these principles of giving testosterone or estradiol prior to the growth hormone stimulation test so that we are able to avoid false positives and unnecessary growth hormone treatment. So we saw what is new in the investigations. Let's go on to what is new in the therapy. Growth hormone therapy regarding dosing. I think these are the previous guidelines and kind of endorsed recently. What is really interesting is to see in children with very severe growth hormone deficiency, the dose has been slightly lowered so that the anticipation is at lower doses you're going to have a better boom, especially if you have more shorter, more delayed bone age, more undetectable the IGF. Probably start off on a low dose and then escalate based on the response to treatment. I think this benefits the whole system in terms of the cost, the burden borne by the patient, as well as without compromising the oxalogical response. And the choice, whether you are going to choose the oxalogy or the IGF base, I think the answer is very clear. Use the oxalogy base. And regarding the oxalogy, whether to choose the body surface area or weight. Conventionally, weight is a preferred modality to calculate doses, but in infants, adolescents, children with Prader-Willi syndrome, I think body surface area is recommended as a modality to choose growth hormone doses. And you have to continue till a growth velocity of about 2 to 2.5 centimeters per year. A word about the long-acting growth hormone analogs. I think this is a big development in the pipeline. And it is an attempt to improve acceptability, tolerability, resulting in a better adherence. Lot of preparations, lot of alterations in the growth hormone molecule are being attempted, and so that the pharmacokinetics are altered and the duration of action is longer. And this is a small meta-analysis of 11 studies where they very beautifully said, when you compare weekly once growth hormone versus daily growth hormone, there is no significant difference in height standard deviation score, no significant difference in the IGF, and no significant difference of incidence of major adverse reaction. And very beautifully, the high velocity SDS are very similar in those who are treated with daily and weekly growth hormone. I think it's a very positive development which we are looking at. And there is even Indian data to suggest that the 1 year response to growth hormone, long and weekly once growth hormone, is as good as daily growth hormone. Only thing they observed was minor injection site reactions, which I think it's something which we have to keep in mind. However, you have to take it with a pinch of salt. There are a lot of unanswered questions about usage of weekly growth hormone. What is the dose of initiation of those who are GH named as well as GH previously treated? And is it acceptable to give weekly once growth hormone without a diurnal variation? Does it lead to an increased risk of antibodies? This is something which is being postulated. And when to sample IGF? I think that question has no answer when you're giving them on growth hormone, weekly growth hormone. And is there a higher risk of intracranial neoplasms? Is something which has not been answered by long-term studies on weekly once growth hormone. So I think both the major companies, innovator molecules, are coming up with long-acting growth hormone, and what they are saying is they are expected to have an answer this available in our country by mid of next year. Biosimilar growth hormone, I think this is a small study which looked into a retrospective analysis of 322 children with growth disorders, and what they observed was biosimilar GH was effective and safe for treatment in a short-term span. So I think in resource care settings, this has to be kept in mind. Regarding long-term response to treatment, I think this is one study who looked into long-term response of children, and what, as expected, what we observed was every subsequent year there was a dip in the growth velocity. So the message is catch them early and be aggressive. What is new in terms of follow-up? I think the newer guidelines have endorsed what was said previously. One additional thing they have said is they have defined what is suboptimal response as well in terms of the height SDS calculation. And they have also very clearly defined what is inadequate response. Your growth velocity SDS is less than 0 or height SDS increment is less than 0.3. I think this tells us very importantly that physicians managing children with GH should use growth velocity SDS as well as explore calculation for height so that we are able to guide them properly. And how to adjust doses based on IGF has been very beautifully defined in these guidelines. So you calculate IGF as Z scores and adjust the doses as it has been shown in this slide. Monitoring, of course, all of us are available, are very well aware of the importance of monitoring for orthopedic complications, evolving pituitary hormone deficiency, glucose metabolism disorders, etc. as discussed yesterday. And what is new as far as the management of idiopathic short stature is concerned? I think the 2019 guidelines is no blanket routine recommendation of growth hormones or an individualized response has to be taken, and start off with a dose of 0.24 per week and scale it up to 0.47. And quantification of response, the guidelines say be very careful. This ISS is like a bouquet which has multiple flowers. So you have a heterogeneous group of disorders grouped into one particular disease, and giving a blanket statement of 5 centimeters, etc., may not be wise. So be very careful and give a realistic expectation to the parents. This is a very interesting study who have looked into the utility of aromatase inhibitors as an addition to growth hormone in children with idiopathic short stature. And last question, what is new as far as addition of GnRH analogs to growth hormone therapy in children with growth hormone deficiency is concerned? I think the Bangalore Krishna consensus statement has very clearly looked into this question and has given a very simple answer that in children who are treated with malignancy, who have precocious puberty and low predicted height and growth hormone deficiency, a strong consideration for giving combined with growth hormone and GnRH analog therapy has been advocated, as well as children who have growth hormone deficiency and very short at the onset of puberty. They have reviewed the literature and says addition of GnRH analogs for a period of about 2 years gives a significant increase in the predicted adult height. So I think these are two situations. They have very beautifully classified this situation of combo GH-GnRH into 5 situations. I think Anurag sir was also part of that consensus. Children who have growth hormone deficiency and who are short. Children who have growth hormone deficiency as well as precocious puberty. The guidelines say go for growth hormone, combined GH-GnRH treatment. Children who have ISS and are going to land up into early puberty and short stature. Be very, very careful. SGA, I think they say, is going to add to a final height of about 6.6 centimeters. So they are advocating the use of GnRH analogs in SGA babies who are short at the onset of puberty. So they have classified this whole group of short children with early puberty and given a very clear answer. I think it may be very confusing if I say, if you read the guidelines, you will really be able to appreciate the essence of what they are trying to say. So I'm just going to sum up what is new, a literature review as far as growth hormone is concerned. What is new in anthropometry and growth charts, the availability of pediatrician-friendly growth charts, the availability of NPH calculator, the availability of BMI lookup tool, the availability of median growth velocity charts. I think these are the few new charts that have come in the past few years for clinicians dealing with growth disorders to practice. Shift of usage of anthropometry from percentiles towards Z-scores in specialty clinics is something which we should strongly consider. If you find height Z-score decline of more than 0.3, be careful as per the 2019 guideline. Regarding the 2009, what is new as far as growth hormone deficiency investigations are concerned, IGF interpretation and adjustment of growth hormone based of IGF based on Z-scores, bone age above 2 years, a judicious usage of growth genetic testing, the new pituitary volume data that is available for us to clinically use, the availability of nacimodulant, a new stimulant probably in the pipeline, a recommendation not to use hypoplastic criteria, pituitary as a sole criteria to make a diagnosis of growth hormone deficiency. And if an index of suspicion is high, obviating the need for a second growth hormone stimulation test in the 2019 guideline and the cutoff of 7 nanograms per ml. Weekly wants new in therapy, weekly wants growth hormone. The innovator molecules are strongly coming up with, which they are saying probably in 2023 it will be available. There is good efficacy in terms of oxology. Local side effects is something which we have to keep in mind. Biosimilar growth hormone, emerging role in resource care settings. Long-term follow-up, IGF Z-score and height Z-scores are something which needs to be kept in mind. Regarding what is new as far as ISS is concerned, judicious use of growth hormone, not in all cases, and aromatase inhibitors are emerging as a potential role in the days to come. We have to look out for that. And what is new about adding GnRH analogs to GH therapy? If the child with GHD is short at pubertal onset and low predicted adult height, or malignancy treated with GH deficiency with precocious puberty, you will have to probably think about this treatment. Thank you very much.
I think once again a wonderful talk by Himchand covering everything on growth hormone in 20 minutes. So I think this was really, I think another round of applause and appreciation. So I'd like to take inputs from Neha and Dr. Aisha.
Very lucid presentation as expected and as always. I have just one question about normal values of IGF and which criteria, which normative values are using. Not confusion.
I think that's a very difficult question. I think the last slide I forgot to put. I wanted to say that the Grow Society should plan a multicentric study to generate normal values of IGF for Indian children, so that Z-score calculation can be done using Mumbai group is there. In,
very limited data.
Very small data set, and if you really practically attempt to calculate the Z-scores, you get bizarre numbers.
The SD is very wide.
SD is wide, so you get -10.
Yeah.
And there's
So-
Western data from Joule et al., which has kindly given normal values for different age groups as well as for pubertal status. I think that is practically easier to calculate and use.
When we have from India.
Yeah.
Meena,
Yeah.
they said that's
Yeah,
what
Dr. Meena study, the problem is that you need to have at least 30 per age per gender. So you would need from 2 to 18. If you have 17 years, you need at least 13, maybe around 2000 will be the minimum sample size you will need. The sample size there was 200, 300. So of course that is not going to make any sense on that. Yeah, that's why I would say that with the use of IGF-1, be very careful in interpreting all the data, and ultimately be careful. Clinical picture is the most important. We discussed oxology, height less than -3 standard deviation. You are more likely borderline height, borderline IGF. Don't worry about that. So I think there's one question, I think finally from Dr. Satyakala in Melbourne, who has posted there, is the role of growth hormone in silver russell, is it different than SGA or is it the same? So
if your topic on this.
yeah, so I was supposed to take the talk on XGA, which we are skipping today. So just to complete that, generally speaking, there is no difference in terms of response, whether it is Russell Silver or SGA, except for methylation defect. So if you have 11p15 defect, in that scenario, you would have a slightly lower response in Silver Russell, but generally speaking, the response is pretty similar. So when we say SGA, it's a mixed bag. It is a mixed bag of people who have got growth hormone deficiency, partial, insensitivity, syndromes, or whatever. But if you talk about particularly 11p15 hypomethylation, response is slightly lower. I think that will be the message from there. So I think I'll thank Dr. Hemchand and Dr. Yuthika for the wonderful session and the talk. And I thank Dr. Chetan, Dr. Ayesha, and Dr. Neha for chairing this session. We will now move forward to the next aspect of this talk. And this is again going to be an interesting grand round. So I think that's what we are trying to do, is to use case scenarios to really highlight the key aspects of in terms of the overall aspects in terms of evaluation, management, and other things. So we now have a grand round on ovaries. So we have already had a big successful grand round on pituitary. We'll now have a grand round on ovaries. And for this grand round, we have got a wonderful constellation of experts who are there. We have got Dr. Subrata Day, who is again going to join with his wit, with his knowledge, and with his inputs. Sir, please come up to the stage. Dr. Yuthika, who has already talked a lot about PCOS and hyperandrogenism. Dr. Vikrant Singh. Dr. Vikrant is a young pediatric endocrinologist from Lucknow. He did training under Dr. Raghupati and now is running his own clinic, Kartikeya Endocrine Hospital, and Dr. Chetan from CPED Rajkot. So, and I'm joined by Dr. Vibha, who will be posting those questions. So we'll focus on three topics basically: hyperandrogenism, oligomenorrhea, and Turner syndrome. A lot of hyperandrogenism has been covered, so it will be like a revision using cases in that scenario. So hyperandrogenism, we all know we should consider if there is hirsutism, acne. Hirsutism is Ferriman-Galloway score more than 15 or more than 8 to 15 if you have a worry in that scenario. Virilization, very important. If you have hyperandrogenism, always look for clitoromegaly, voice change, muscularity. That is a dangerous sign. That means that the patient has some tumor cause of that in that scenario. Alopecia, hidradenitis suppurativa, these are the other cutaneous markers of the scenario. Remember, when we say hirsutism, we should distinguish them from vellus hairs, which are normal, soft lanugo hairs, as compared to hirsutism, where you will have androgen dependent hairs, which are longer, coarser, blacker, curly hairs. You should also distinguish from hypertrichosis. This is from diazoxide toxicity, but other conditions can cause that. And look at specifically in a androgen dependent area. So you should use Ferriman-Galloway score to rate that. There is a whole in our application also. You just have to select the site and you will get the exact FGS coming out of it from their regards. So if your Ferriman-Galloway score is less than 8, that is mild hirsutism, don't evaluate in an adolescent. If it's more than 15, even if your testosterone is normal, this is significant. There is a clinical hyperandrogenism. Between 8 to 15, you can look at testosterone level, get a morning testosterone sample. If testosterone is above 55, this is significant. Below 55, unlikely. Now, whether we do a free testosterone, which is a more sensitive assay, I would say it is not very, very clinically relevant. But if you think there is hyperandrogenism and your total testo is normal, you can do a free testosterone, but that's adding to the cost in that regard. Once you know this is hyperandrogenism, the next question is it coming from the ovaries or is it coming from the adrenals? So if you have a high DHEAS, you are most likely dealing with the adrenal pathology, and this will suppress to DEXA. So DEXA suppression is a good marker to identify adrenal etiology, and we had a wonderful case which Sayan presented yesterday as to how steroids suppress the whole process, that is a FAH, functional adrenal hyperandrogenism. Most of us don't use GnRH response, but that is more of an experimental test in ovarian cause in that regard. Now, when to do a 17 OHP? If your 17 OHP is pretty high, more than 1000 nanogram per dl, you have to start considering non-classical CAH. 170 to 1000, you should do a synaptin test. Less than 170 is normal. Remember, 17 OHP should be done in the morning and in the proliferative phase. If you do it post-ovulation, your level will be falsely high. And suppose you have an amenorrheic girl and suddenly she ovulated in that cycle. So in that situation, falsely, your progesterone will go up and your 17 OHP should go up. So in that scenario, if you are doing an amenorrheic girl, do progesterone and 17 OHP, and we'll have a case to discuss that as well in that regards. So day 2 to 10 of periods, high with ovulation. If you want to confirm an ovulation, progesterone less than 175 is what is recommended. Just to summarize, if you have hyperandrogenism, the key question is if there is no features, don't work out. Otherwise, mild hirsutism is very common. If there are features of hyperandrogenism, are there virilizing features like clitoromegaly, voice change, testosterone more than 150? Yes, this is tumor. Go for adrenal, ovarian imaging. If it's not there, work up basic causes, thyroid, prolactin, maybe cortisol. That is also important. DHEAS more than 700, like our case which we saw yesterday. Adrenal imaging becomes important. Less than 700, 17 OHP, and then you go for PCOS. So this is the way to go forward. We'll start with the first case, Dr. Vibha.
Thank you, sir. Good morning, everyone. So, a 14-year girl came with a complaint of increased facial hair growth. She had a first period 1 year ago, and she had a complaint that she is having period every 2 months. And on examination, we found that the Ferriman-Galvez score was 6. And on USG, it was showing there is a polycystic ovarian appearance, and she was diagnosed as PCOD. So I would like to ask, ma'am, sir, is it right to label it as PCOD at this age and with this clinical complaints?
No, I don't think so. We should be labeling this girl. So within a year of menarche, as it is, you have irregular periods because of the hypothyroid, pituitary axis being immature. They have chronic and ovulatory cycle as a physiological. And her lymphodism is also very mild. So Ferriman-Galvez score of 6. So I would definitely not want to evaluate her. I would not have done an ultrasound because ultrasound definitely you get that label. It's very difficult to diagnose a polycystic ovary and differentiate it from the multicystic ovary. And as it is, any chronic anovulatory state will lead to a polycystic ovarian appearance. So definitely we should not do evaluation unless it is significant hyperthyroidism or there is menorrhagia or there is 2 years post.
So the key message is basically no role of PCO appearance in adolescents. Don't go for ultrasound unless you're looking for virilization. That is different. Then go for CT. FGS less than 8, forget about it. That's normal pretty much in that scenario. Avoid workup within 2 years. That's what Dr. Yutika said.
Thank you, ma'am. Now, another 14-year-old girl came with the same complaint of increased facial hair growth, and menarche happened 1 year ago, and she also had the complaint of having periods every 2 monthly, but she had noticed some body changes like change in voice, increase in muscle mass, and increase in facial hair growth and increase in growth over pubic hair, and she was also labeled as PCOD. So I would like to ask Shubhrata sir, how should we approach these types of cases?
Firstly, as Dr. Anurag is very eloquently enunciated, an FGS of more than 50 is red alert. And I think that's the most important message. Second thing is muscularity. We recall yesterday's pocket Hercules. The 2-year, 9-month-old was muscular. And that's why I called him Hercules. So muscularity means there is an element of high levels of androgens. So this requires investigation and not to be blown away by the PCOD thing. And just to actually reaffirm what Dr. Yutika said is nowadays, especially among gynecologists, it's rampant to do a USG, see the little cyst and say PCOD. And the mothers say, oh, मेरे को भी PCOD है, बच्ची को भी है, ये तो एकदम inherited है. So beware of this philosophy. So bottom line is, yes, this requires evaluation, and I think
So
Anurag will take us through the flowchart.
Yeah. So the workup we did was testosterone 230. So this is huge. This is male level of testosterone. DHEAS was 900. So as I said, 900 is a huge level. And we basically, if we go by this, we found this the same case in a different scenario, a large adrenal. This was a carcinoma basically. So be wary of an adrenal carcinoma in young girls with rapid onset virilization and progression. That would be the key message. DHEAS is a good marker, more than 700. Very, very careful. Sometimes it may be 3-beta HSD rarely, but tumor is the first thing you want to exclude.
I have a question for you. You know, in premature adrenarche, which also has DHEAS in a 300-400 level,
Yeah.
the parents look at that number and they have this, little girl with a little amount of pubic and axillary hair. They want that to be treated.
Yeah.
What are your views on that?
So first thing, if your DHEAS is less than 30, that is isolated pubarchy. 30 to 150 is premature adrenarche. More than 150, definitely more than 200, I will be wary of CAH, and very rarely the same adrenal carcinoma. If it's more than 150, 200, we will get at that age, that is very high. We will get an imaging done, we get a 17 OHP done. Now, coming on to the treatment, there is no specific treatment in this, but we know that this is a part of metabolic syndrome. So this is basically SGA, rapid catch-up, metabolic syndrome, precocious puberty. So in this scenario, there is one big study which was done in Brazil, which basically Dr. Ziziger and the group had done, which shows that if you have advanced bone age, you can use metformin as an agent. I have used in a few patients whose bone age was 3-4 years advanced, no breast development, only adrenarche, and that seems to be working, but based on 4 or 5, I can't say whether it is there, but this could be something who has a very advanced bone age, and DHEAS is 200, 250, lot of hairs. They will be metformin is the only thing which I think of.
Were they obese?
No, they were lean, but their fat was more. So we have got the BIA and DEXA, so we got their fat was 35-40%, but they were not obese. So this is again that Barker's hypothesis playing around in that regard.
And the important determinant is they were all GI.
Yes, they were all SGA. They were all SGA. So SGA with precocious pubarchy is alag, and LGA and obesity with precocious pubarchy, that is more like a milder early puberty. Then SGA is a sinister thing. So next.
Thank you, sir. 15-year-old girl came with a concern of hair all over the body, and she had normal menstrual cycle. There was hair all over the body. There was no history of increased hair growth. The FGS was 3, and she gave the history that her father has the same hair growth pattern. So I would like to ask sir, how should we counsel these patients? They were very much concerned about the hair, especially the girls. So what counseling should we give?
Yeah, we have to counsel them regarding the difference between vellus hair, hypertrichosis, and hirsutism. We have to tell them the hair has been present all over the body, and there is a familial predisposition to it. As you have told, the father was likely going to be a hypertrichosis and Fahrenheit score, which is pretty much low. So we can pretty much assure them we are dealing with the innocuous thing like hypertrichosis, which is a familial component, and we need not to worry about it.
I think the major concern mothers have is that this is going to cause some hormonal problem. So this is what Dr. Vikrant excellently said, that this is just a cosmetic local issue. It has nothing to do with hormones. That is the primary thing, the message we give. So this was basically hypertrichosis, nothing to be done. And this is very, very important, Professor Pratap.
One very important message for the delegates is that hirsutism is male pattern hair growth. So it's all the face, the axilla, the lower abdomen, and the chest. Hypertrichosis is hair all over, and that is heritable. But in the Fedman-Galloway score, if you look at it, there is hair in the back, hair on the legs. So one very important distinction, whenever you look for hirsutism versus hypertrichosis, is do you have hair in the male pattern hair? And I think to start with face, chest, and if a girl has chest hair and has facial hair, that is hirsutism.
Especially around the nipple area. That is the very, very characteristic sign of a pathological cause. So that becomes quite.
And it's a clinical thing, and it's very important that the hypertrichosis, usually the dads are hairy, and the daughters inherit, they look like their dads, and they're hairy, and the mothers are worried because they have no hair, though. They look very feminine. So you can.
Thank you, sir. A 16-year-old girl came to us with a complaint of increased facial hair growth, and she had amenorrhea, no period since 3 months. There was no history of obesity and no history of galactorrhea. On labs, we found that her testosterone was 68 nanogram per dl, and her 17 OHP was 600 nanogram per dl. So I would like to ask Chetan sir, what should we do next? Should we rely on this single report, or we should run some other test?
So in this report, we have testo which is high, that is 68, and we have 17 OHP, that is borderline between 170 to 1000, as sir described earlier. So non-classical CAH is out, but we need to confirm it by doing ACTH stimulation test, whether it rises after giving cyanoxylin or not. Second, as sir rightly said, even in amenorrheic girls, if there is an ovulation, so progesterone might be high. So again, we should be doing progesterone as well, along with the 17 OHP. So normal ACTH test rules out the in a non-classical CAH, and progesterone was high. So this is suggestive of ovulation induced high 17 OHP, but testo is high. So this might be a candidate of other causes of ovarian hyperandrogenism, maybe PCO-like picture. So
I think that is a very critical message which Chetan has given, that if you have amenorrheic girl, you don't know whether ovulation has happened in this cycle or not, you do both progesterone, easily available, robust test with 17 OHP to avoid this confusion. So I think the message is 17 OHP should ideally be done in proliferative, but if you have amenorrhea, you don't know which phase you are. So simultaneous progesterone will help you out.
Thank you, sir. A 15-year girl came with a complaint of hirsutism. She had menarche at the age of 13.5 years, and she had period at every 3 months. On examination, we found her FGS score was 60, and she had severe acne. On labs, we find her testosterone was 64 nanogram per dl, and the USG, they reported PCO appearance. So I would like to ask Dr. Shubhato, what should be our approach? How should we go further in this case?
This could very well fit in with PCOD. Testosterone more than 50, FGS more than 15. There is certainly hyperandrogenism. Now,
so what sort of management would you treat this girl or not? She is within 2 years of her menarche. So often people say wait for 2 years, but this girl is already at hospital. So what will you do? Will you wait for another 6 months to let her become 20 FGS, or you will start treatment? That is the big question.
I think we have to evaluate further. And I think in hirsutism in girls, the current philosophy is PCOD unless proven. And I think the paradigm shift, and that's where the pediatric endocrinologist comes in, or even pediatrician, to take the ball away from the gynecologist and say, maybe let's look at other things.
Yes, 17 OHP was normal, DHEAS was normal. So this looked like a classical functional ovarian hyperandrogenism as in PCOS. So the question is, how long do we wait? Now the problem is hyperandrogenism begets hyperandrogenism. Your androgen is more, ovary will become virilized and your pituitary will get knocked out. So probably a lot of people say that if you have at risk, so this will be at risk within 2 years. That's what Dr. Yutika talked about. Probably we will be heading a treatment because 6 months here and there is not going to make a huge difference, and she may become worse if we don't treat and then reassess again in 5 years. That is the major thing, that it may be a physiological hyperandrogenism. FGS of 16 is a bit too much for physiological, so better to start, manage as PCOS and see at 5 years what happens post-menopause.
Basically, just as Dr. Yutika would have enunciated, that the treatment of hyperandrogenism, the treatment of PCOD-induced hyperandrogenism, there are two very powerful tools. One is, OCPs, and the other one is anti-androgens. And the OCP is within the, especially the Yasmins and the GnRH, which definitely makes a difference. It makes the period regular. But the anti-androgens, which like spironolactone, it has a huge role. And I definitely think it works. So I think the answer to this question, A, will you take cognizance? Yes. Number 2, will you look deeper to find the cause? Yes. Number 3, will you treat with these two modalities?
Thank you. So I think very, very clear. So if you have an at-risk PCOS with severe symptoms, you have to definitely consider treatment. In that scenario, that becomes important, but you have to reassess them once they become 5 years post-menopause.
Thank you, sir. A 17-year-old girl came to OPD with a complaint of hirsutism, and she had menarche at 42 years old, and she had a complaint of oligomenorrhea. On examination, we found her FGS was 18, and she had acne. Her BMI was on the higher side, 32. On lab investigation, we found testosterone was 72, and the USG report showed there was a PCO appearance. So I would like to ask ma'am, how should we manage this case with a girl with PCOS with a high BMI?
So this is beyond 2 years of menarche.
Okay. So I'm assuming that all of the tests
All workup is normal.
All workup is normal. Well, definitely at 17 years, with moderate to severe hirsutism, obesity, and irregular periods, she is a definite case for treatment, a very urgent treatment. She's already lost a few years, so I would call this girl as someone who has had a prolonged hyperandrogenism for a significant period of time. So the chances that she will revert back goes down, and the chance that she is a true PCOS is higher, because she's that many years post-menopause. So definite treatment is needed in her case, and a complete gamut. So you need to do lifestyle for her because she's obese. Maybe add metformin, and definitely the estrogen and progesterone pills. And because her perineal caliber is significant, maybe add anti-androgen. From the start as well, the testosterone is significantly high. So we need to really look at whether our drugs are working. So if we follow it up with the testosterone level. So do a complete treatment in this girl, because definitely she is one who is going to land up into PCOS later on also. And counseling and all those things are very important, because they will require a really long-term treatment. And definitely they need to understand that having regular cycles in this age group is important for them to have regular cycles later on. So chronic and ambulatory scenario has to be stopped.
So she was started on metformin and OCs. What happened at 3 months? Periods were regular, weight was lost, hirsutism was the same. What do you do?
So again, hirsutism, as I said, it takes time, because the growing hairs have a phase. So before 6 months, hirsutism changes and clinical changes very difficult to make it keep counseling them that this will work. But definitely because her testosterone was high, and if you have a cracky family, maybe get a test done to show that things are happening, but keep counseling. Otherwise,
and I think one error will often happen is people get total testosterone down, and total testosterone will falsely be high. So they will say, "Pehle to wo 60 tha, ab 100 ho gaya," because they are giving estrogen, it will be high. So tell them this is useless. Get a free testosterone. So don't get confused. A lot of people get a testosterone and ultrasound also in the same. They will come back after 3 months. So
they get the testosterone done themselves and come back.
It's because the SHBG is.
Yes, SHBG increases with the issue. Now 6 months later, no improvement in hirsutism, weight gain, cosmetic measures were given. So I think Dr. Yumika said right away that we should have given spironolactone right at the beginning. So if you have severe hirsutism, we should not wait, but in our protocol, we said you can wait for 6 months. So now we will think of spironolactone. Now what happened 9 months later?
9 months later, everything was stable, but she had intermenstrual bleeding, and she was very concerned about it.
What should be
So what should be the cause of intermenstrual bleeding? And
usually, if it is because of clothes-related intermenstrual bleeding, it will present earlier. So if it is happening later on, most likely it is adherence issue, and we need to see whether she is missing out on the things. But definitely, sometimes with a very prolonged use of estrogen progesterone, maybe you develop a really thin endometrium. So if it is not working, and if you think it is not adherence issue, you could get a ultrasound done to look at the endometrial thickness. And if it is very thin, then you can add estrogen to it to prevent the intermenstrual. But again, it's not a very significant thing. So if somebody has intermenstrual bleeding and she is not on any estrogen progesterone combination, then it is dangerous. It could be endometrial hyperplasia, endometrial polyp. But if somebody is on the pill and intermenstrual bleeding, it is less likely to be any plastic things happening. So it is less dangerous, but more irritating.
And on follow-up 1 year later, her hirsutism improved, weight has decreased, and periods become regular. And I would like to ask them, till how many years or how many months should we continue the treatment?
In this particular patient, because we started late, so she was already 17 years, 4th year postmenopausal, and she had a significant hyperandrogenism. So she is in that high risk category where she is going to be up to PCOS. But generally, I would want to keep her 5 years postmenopausal. For her, she is already 19, still 19 years, stop and see. So another year of treatment.
So key messages are that if you have obesity, give E plus P and metformin. Maybe consider aldactone if it's a very significant hirsutism right at the beginning. Lag phase is there for hirsutism to respond. Continue treatment for 5 years post menarche. That would be the situation.
I have one quick comment. About a decade ago, there was this doctor from Spain, Lebanese, who prescribed for these patients a combo of metformin and glutamide. And glutamide has liver toxicity, but it's an extremely potent antioxidant. So glutamide, OCP, and 5. This combo, she won the whole world over. But 2 years later, she suddenly disappeared from the scene because they found that glutamide has a lot of liver toxicity. You penetrate their liver enzymes very carefully. And that dose is much safer and certainly works. So a decade ago, I used to have more patients on glutamide. And the interesting thing is, I moved away to aldactone.
I think when you give aldactone, always counsel the family that this is a hypertensive drug, because otherwise somebody will say, "उन्होंने आपको BP की दवा दे दी, गलत दवा दे दी." Tell them that this is not being used for that. I had faced lot of issue with just using aldactone. But at the end, nothing happened. But parents were, somebody told that you given BP medication and everything, and monitor electrolytes and blood pressure. These will be
just like metformin.
Yeah.
Diabetes का दवा दे दिया, वो diabetes का दवा दे दिया, क्या कौन से डॉक्टर के पास जा रहे हैं? So you have to also learn there's something called anti, insulin levels versus anti, and conversely, what a lot of dermatologists will do fasting and PP insulin levels, and nothing. वो parents का होश उड़ाना है, तो बस वो insulin level दिखा लो, 200 post prandial, and what do? वो paper से आप aeroplane बनाओ और फेंको.
Sir, I have a small query for Deepika ma'am. Ma'am, what should be our strategy to perimenopausal PCOS sometimes? Just not a part
that
of
is
the
beyond this. We'll discuss it in the team day.
I just wanted to add for this patient. When I said you continue treatment for another year, aldactone is something that you might want to, because the idea was to correct her hyperandrogenism. Hirsutism has become better. That is what you can taper. But we want to continue the estrogen and progesterone for a longer duration. So once you correct her chronic anovulation, her further hyperandrogenism is already corrected. So you can get down on your aldactone, but then you can continue with it.
Thank you, ma'am. 16-year-old girl come with a complaint of hirsutism. She had this complaint since 1 year ago, and she complained of irregular menses. And whenever she had periods, there is heavy bleeding. And on labs, we find her testosterone was 90 nanogram per dl, and USG show PCO appearance. So I would like to ask Dr. Vikrant, what is the cause of this heavy menstrual bleeding during her periods, although she is having irregular periods?
And more importantly, how will you manage this? So this is PCOS with menorrhagia.
Yeah. So first of all, I would like to control menorrhagia. I can do progesterone or something we can, and later on we will shift into higher doses of progesterone as ma'am and rightly pointed out.
So I think this is very important, because this, first of all, of course, progesterone has to be given to control, and then 50 micrograms or something. And many of them are large girls, big girls. Often the 30 may not be good enough. 35. Yeah, so 50 would definitely be recommended. Very important. So if your menorrhagia started, high dose estrogen, and then go back to the scenario. So high dose estrogen with severe bleeding.
Thank you, sir. A 16-year-old girl come with a complaint of severe hirsutism, and her FGS was very high, 28, and she was very concerned about her irregular periods. Her testosterone was 110, and USG reported PCO appearance. So I would like to ask Dr. Chetan, how would you approach this case? How would you manage this case?
So all other causes ruled out. It is PCOS with severe hyperandrogenism. So a special scenario.
So very high American Galvez score along with the testo, which is very high range of the cutoff is more than 55, so it is double. So definitely, as Dr. Yutika pointed out, that we can give longer cycles of continuous 3 months of estrogen followed by one winter of bleeding of progesterone. So that will effectively decrease the testo.
This is a very important way. Now, what you need to understand that if you give for 21 days, 7 days off, only 75% you're treating. But if you give for 2 months, then or 3 months, also this would be a very good way of giving estrogen. Estrogen increases SHBG. That is the primary role, and that is going to help you out on that. So continuous estrogen in somebody who actually has severe hirsutism. So we have discussed about various cases of PCOS, too much bleeding, too much hirsutism. This is 17-year-old girl, not 7.
17-year-old girl came with a complaint of hirsutism, which occurred immediately after the menarche, and there was a rapid progression of increase in hair growth, and she also complained of amenorrhea, no periods since 3 to 4 months, and increase in the muscular mass. And no, there was she noticed voice change also, and her testosterone level was 200 nanogram.
So this girl had onset immediately after menarche, but it was mild. Suddenly, last 6 months, she has exploded, and she's having rapid fever. So was there a low-grade tumor, and now it has become a high-grade, or what has happened in this scenario?
So I think the dominant message from such a case is investigate till you find nothing. And Again, the adrenal is the biggest offender. You can get ovarian neoplasms. You can get germ cell tumors. So before you say everything is okay, you have to do an extensive workup. And one may argue you may have to go up to a PET scan to make sure there is. Now, after you have truly ascertained that everything is okay, then as this USG shows, a thick thecal membrane. So this is hyperthecosis, and this is the diagnosis of exclusion, right? So diagnosis of exclusion, and this is where we need the gynecologist, the endogynecologist to ratify this. So bottom line is be very, very meticulous to make sure that every other possibility is. And of course, as Dr. Rag has put up there, you have to do all of the above. Now, was this patient amenorrheic?
Yes, for quite some time. So this is what will happen if you don't treat at the right time. So she had problems and everybody was waiting, okay, theek ho jayega, everything will be fine. Within 3 to 4 years, there was a sudden increase which happened, which means now the ovary was becoming, there was a threshold happening and suddenly ovary became hyperthecotic and then these changes started happening. So this is a message that early treatment, don't defer treatment if it is needed. Don't treat if it is not needed, but don't wait and watch. If it is needed, don't wait. Otherwise, you will develop this. This is a very, very difficult condition. It looks just like an ovarian tumor and adrenal tumor. And Dr. Hemchand last year we presented in New York, and there was a case on this hair-and syndrome presenting as hyperthecosis. So these are all very, very complicated cases, very difficult to treat. They will realize you may, some people say remove the ovaries. That is the ultimate measure because nothing seems to work in these cases. So this is something.
And it's bilateral, right?
It's bilateral. So it's like a general ovaries have now gone into an autopilot. So they are continuous producing. So they are like factories of androgen. That's
So
what I
now
mean.
they've become testes.
They have become testes. So you block them with GnRH analog. You give estrogen as a backup to increase SHBG. You anti-androgens. You give metformin. But nothing works. It's a very. Yes, this is the first. So this is that most severe one.
So have you actually encountered?
Yes, we have seen.
And what was the outcome?
It was very difficult, and we gave GnRH analog, add back this thing, clitoromegaly stopped, and then they were lost to follow because nothing was happening. We said that we might have to remove the ovaries, then they probably went to somewhere else for consultation.
I actually saw a patient with hypertrichosis in a post, say, a 35-year-old, and who was PCOS, married young, had kids, and then had chronic endocrine. She never cared for it because she already had babies, so previously had already had. And then, 10, 15 years, no period. Eventually, perimenopausal age, 38, 39, went into severe hirsutism, virilization. So we had to remove the ovaries.
This is a very
very prolonged chronic inoculation, hyperandrogenic situation begets hyperandrogenism, which leads to hypertrichosis. So that's why I treat them early, and it's very important even when the family is completed for them to have regular periods.
So tell us about this wedge resection because it reminds me of an MBBS group. That is what was proposed there.
Yeah.
What is the status?
So when we never had these diagnoses with fancy tests, the patients would have presented very, very late, usually say about 10, 15 years of amenorrhea and chronic inoculation and hyperandrogenism. So usually only those women were getting picked up with severe clinical hyperandrogenism. We have pictures of those in many lines. It used to be labeled steam miracle syndrome. Because these guys, opened up the me and, partially resected the ovaries. And then they took out a lot of theca tissues, which is eventually basically.
It's like partial oophorectomy.
Partial oophorectomy, and then their period started. So that's how this syndrome began.
For such a young girl, so this is not unusual to a total hypertrichosis
happen. It can happen. So she had 5, so 5 years was already there since menarche, and right at that time she had perimenarchal hyperandrogenism. And yes, 4 years or 5 years after. So it may happen really because some are more sensitive, and often they will have a insulin resistance syndrome, severe acanthosis. So like what is labeled as hair and acquired, so that sort of. Yes.
So would you recommend?
No. Now we can use GnRH because now we've got looking towards menopause.
So you
And
knock
in
off
this
the.
situation, definitely not because we have to preserve fertility. But if that is not working very well, I think there are case reports of doing laparoscopic validity in these patients.
Like some people talk about adrenalectomy in CAH. Adrenal is doing nothing good, it is causing harm. Same year, ovary is doing nothing good, only causing harm. And another desperate measure, this is the last resort. But the patient went off. So we don't
So
know.
one quick, this 2 years adage which you have been enunciating, post menarche, that is because they have anovulation.
Physiological. That is a physical. So most patients with physiological anovulation should resolve by 2 years. That is the concept.
And you have some hirsutism associated with that.
You can have mild hirsutism.
And this case is where it started slowly, then it rapidly accelerated, and it became a huge problem. So I think, despite this, let's wait and watch the first 2 years, but have a very close monitoring eye, because these patients can certainly take off and cause problems, as was enunciated.
I think wait and watch strategy is only for patients. So if there are some high-risk patients who will, that they are PCOS, because the definition is saying that you have to wait for 2 years. So if you have a patient who has history of overweight, family history, infertility, IVF baby, or maybe premature puberty, obese, those are the patients where and moderate to severe chronic anovulation, you can begin treatment also. So that spectrum.
So at-risk PCOS, the case we discussed with you, if we treat at that time, don't wait for another 1 year, the patient will not land up here. Otherwise, there will be a problem. So early treatment when needed, no treatment when not needed. That is the key message. I think this will be the last case we will take up before the break.
Thank you, sir. A 15-year-old girl came to OPD with a complaint of scanty periods. Her menarche started at the age of 13 years, and she was having periods every 6 weekly, and for the duration of only 1 day. And she was advised estrogen and progesterone pill.
There was no hirsutism.
And there was no hirsutism. And so I would like to ask, ma'am, how should we manage this case?
Firstly, periods every 6 weeks, I would not call it infrequent, because there is a definite recommendation of when you say, and this is based on what actually would be hypoestrogen, what they don't actually need to happen. So if somebody is having periods every 6 weeks, regular cycles, not heavy, no hits, they don't need any treatment unless they are longer duration. So in the first year, if you say you have less than 4 periods in a year, less than basically we will in this third post-menarche year, less than 8 weekly cycles. That is what we recommend for hypoestrogen. The treatment is only when there is basically estrogen is needed for more natural, unopposed estrogen will lead to endometrial activation. So you need for people who are having very scanty periods. The definition of scanty.
So I think this is a big message. Do not over-treat. This is a physiological phenomena which will improve over time. No need for treatment in this scenario, and this criteria does not fit. So this is often unnecessary pain. This is like delayed puberty in boys. You say wait till 14 years. Same thing is happening here. The girl has started walking, like it's like the toddlers, what Yusika often says. They will have khadayenge, they will fall down, and then they will have a stable thing. So they will take 2 years to mature their and no need to go from there. So I think because of paucity of time, we have more sessions to carry on. We had a good discussion on hyperandrogenism. We'll stop here. I'll request Dr. Mahesh to hand over a memento of appreciation to Dr. Yuthika. Mementos. So this has been a wonderful session. I'd like to thank Dr. Vibha for being part of the program, along with Dr. Chetan, Dr. Subrato, Dr. Vikrant, and Dr. Mahesh has been with us at AIMS. We remember those days as well. And we can have the mementos. सारे मोमेंटोस मंगाते हैं तो पहले से बताया. So in the meanwhile, if there is any question on these issues of oligomenorrhea and hyperandrogenism, we can take while we have some time in that regard. And at that point of time, please stay here as well. So we'd also like to thank our fellows who have done a lot of hard work during all this process. So we call them one by one: Dr. Sayan, Dr. Naveen, Dr. Manoj, and Dr. Vibha. So they give a big round of applause. They have been working hard for more than a couple of months for getting all these on-site as well as this course in that regard. So, Dr. Yuthika, will you please give mementos one by one to Dr. Sayan? Dr. Narayan? Dr. Sayan? Can I have a group photograph? I also like to thank our support staff who have been working hard for this process. Aditya, Nikhil, Hariom, Dubeji, Durgesh, all the staff and all the people who have come from different places to work on this. We will now have a short tea break for around 10 minutes. Most of you have had tea, I know, because it was getting a bit late. But if you want to just roam around for 5-10 minutes, we then start with the adrenal gland now. Because the time is important because everybody has to leave. So we'll try to do it absolutely on the clock. So maximum 10:45 we will restart the program. You can go around, maybe relax your muscles a bit.
So go to Cincinnati was southward, that's northward, and they're very nice people.
ये सबको दे दो, हाँ, दे दो, अभी दो, हम अनाउंस कर देते हैं, माइक दे दो, माइक वहां से ले लो। Okay, so we'll be joining after a short break. For the adrenal grand round. And for this grand round, again, we have got the galaxy of speakers who are there. We have got Dr. Hemchand Prasad, who has delivered two wonderful talks in the morning. And he will be part of this panel from Mehta Hospital, Chennai. Dr. Ayesha from Aligarh. Dr. Vijay Jaiswal from Meerut. And Dr. Chetan again, we are not going to leave him. Chetan is occupied all the time. So we'll try to go through the common conditions of adrenals in a case format. So it will be very precise. We'll try to focus on adrenal insufficiency, probably CAH, and I don't think we might be able to cover Cushing. That will be a different ballgame. We'll see how time goes on that. So we'll start with adrenal insufficiency. Now, when we talk about adrenal insufficiency, the possibilities are that the problem could be at the level of the hypothalamus pituitary, which is the central adrenal insufficiency, which is cortisol deficiency. Importantly, here the renin, angiotensin, aldosterone axis is normal. So you will not have hyperkalemia. You will have hyponatremia, but there will be no hyperkalemia, no pigmentation. It can be genetic, lot of trauma, exogenous steroid. Second level is ACTH resistance. Here you will have pigmentation with hypoglycemia with normal potassium. Sodium will be low, but potassium will be normal. And finally, this will be the familial glucocorticoid deficiency, like we saw a lot of cases in the on-site course also, we saw very cases. Third stage is a primary problem in the adrenal, where you will have pigmentation, hyperkalemia. This could be a steroidogenic defect or a hypoplasia, as adrenal hypoplasia congenita, and hemorrhage and other problems can cause this. So if you have hyponatremia, headache, hypoglycemia, easy fatigability, hypotension, hypercalcemia, think of cortisol deficiency. And I said 4 things. If your insulin requirement goes down in diabetes, vasopressin requirement goes down in central DI, antihypertensives go down in hypertension, and calcium requirement go down in hypoparathyroidism, that may be the first sign of evolving cortisol deficiency. This is what we need to really understand in that regards. So how do you diagnose? Most importantly, single low cortisol is a useless investigation. Unless the cortisol is low along with hypotension, hyponatremia or shock, that is significant. So stress value less than 138 is 100%, less than 550 also you have to worry. Otherwise, you should do a stimulation test. Now, Synaxan is available. We had a good discussion of how do we do that. And 8 AM value is not of much role in that regards. Now, when you measure ACTH, remember ACTH is a labile hormone. If you don't send it to eyes, the value will be lost. And there is a log linear relationship between cortisol and ACTH. If your cortisol is low and ACTH is more than 300, this is adrenocortical. Less than 300 is inappropriate, and this would suggest central. So this correlation of end product and that becomes important. In terms of infancy, we need to remember that the levels vary. So you have different cutoffs. Younger children within the first week less than 100. By infancy less than 70 and otherwise less than 138. So lower cutoff are used. Also remember that there will be a lot of other metabolites which are accumulating in the newborn period. So your immunoassays are not good enough. You have to go for a GCMS based assay. Extraction and GCMS. There is no diurnal rhythm. So don't say any newborn, you do it in the morning, you can do any time of the day, which is possible in that scenario in that regards, and repeat thrice before you make a diagnosis. So if your ACTH with low cortisol is less than 300, this is central, go for MRI. More than 300, less than 6 months, rule out CAH and adrenal hypoplasia congenita. Above 6 months, ALD becomes important, and then you go for autoimmune causes. So first case, Naveen.
We had this 12-year-old boy who was a patient of a chronic liver disease. and they evaluated the electrolytes, which found that the sodium was low, which was 128, and also found that the potassium was also low. And on further workup, they found that the urine sodium was also very low, and on clinical examination, it was suggestive of fluid overload, and they also got a cortisol level done, which was very low for the level of hyponatremia, and the treating physician advised hydrocortisone. So, Dr. Hemchand, would you like to start hydrocortisone in this case, and do you would like to revisit the diagnosis of cortisol deficiency in this case?
I think this is a classical case of a sheep in a wool story. This is a simple sheep whose carrying as a piece of wool. The important clues in this child before making a diagnosis of cortisol deficiency, just on the basis of a low cortisol level, please look at the potassium level and please look at the urine sodium level. Usually, whenever you have cortisol deficiency, you expect that the child should have an increase in the excretion of urine sodium, which is significantly low in this case. And remember, the sodium and potassium are two sides of the coin. Whenever you have adrenal insufficiency and immunocorticoid deficiency and sodium level coming down, potassium should index. That is not happening in this case. So just because the child has a low cortisol level, don't make it. Remember, hepatoadrenal syndrome is a very well-described entity in children with chronic liver disease that has to be well managed. But in this particular case, remember there are a lot of fallacies which can influence cortisol level in a sick child with chronic liver disease. The important factor that one has to keep in mind is the hypoalbuminemic state, which is documented in children with chronic liver disease. The low albumin level results in a low total cortisol level and then an appropriately normal cortisol level. So these children do not require cortisol treatment. This is the case of a sheep in a wool state, masquerading as cortisol deficiency, but they don't have cortisol deficiency. The clue is normal potassium or low potassium, and the urine sodium, which has two simple clues to stop you. And whatever it has prognostic value, they can have limited adrenal insufficiency, chronic liver diseases. Hepatoadrenal syndrome is documented. This child won't start.
So moving on to the next case, he had a 3-week-old child with a failure to thread. The birth weight was 2.7, following with the child weighed only 300 grams next 3 weeks. And on evaluation, a sodium and potassium were found in the normal range. And random cortisol was done, which showed low levels of cortisol. And do you like to treat this patient with hydrocortisone, Dr. Aisha?
So we have a 3-week-old girl who is not getting weight gain. The electrolytes are normal and the cortisol looks well below level. So somebody has advised. So I would say don't rush to the numbers. So there's a catch here. So you have a look at the age of the person. Before chasing the numbers, you have to just remember, as Adla has very rightly pointed, that in infancy, especially in the values cutoffs are different. You always have to, before rushing to conclusion and starting treatment, always have a look at the child, and during infancy, always check for the cutoff. We have different cutoffs at different levels, so age appropriate estimation and taking for normalcy is of fair amount of time.
So in this case, the cortisol was actually higher than the cutoff, so it should be less than 70, and you can do any time of the day. This was another message, don't wait for that. So what I'm trying to say is that just a single cortisol anyway doesn't have a value if you do not have hyponatremia, hypoglycemia, shock, hypotension, and very well Dr. Aisha said that non-stress cortisol is unreliable in infancy. Even with hypoglycemia, we have seen many cases of transient hypocortisolism, which may be a born out adrenal. So once you have a lot of hypoglycemia, cortisol becomes low and then it recovers later on. But then you should ideally do a GCMS or a repeat sample.
We had the another case with similar complaints in a 2-month-old boy with failure to thread, and his weight was 2.5 kilos at 3 months of age. And on electrolyte investigation, the patient had hyponatremia with hyperkalemia, and at the level of hyponatremia, the cortisol was 60 nanomolar per liter, and with high levels of ACTS, and 17 hydroxycholesterol levels was there, which was not very high, slightly higher than the normal range, and there was no ambiguous genetic in the child. So how do you proceed with this case, Dr. Vijay?
Thank you. So this is a 2-month boy, and of course you can see the weight and length that it is failure to thrive. Sodium on the lower side and potassium bit higher, that is 6.2. Cortisol is low, and in compensation, ACTH is high, that is beyond 300. So it means that we are looking for primary cause, that is the lower side, that is adrenal cause. And 17 OHP is a bit higher, testicular volume is 1 ml, and slash phenyl level 4.5. So again, I have to see some more things. So how we have to approach that? In case of low cortisol, we have to pinpoint whether that what is the site and how we are going to decide the site, that we have to take the consideration of ACTH level. And again, not only ACTH level, that at what age group you are going to deal with. So if low cortisol and this less, that is low ACTH, it means that you are dealing the higher side, that is center, and MRI head is going to be recommended. If you are going to have the low cortisol and high ACTH, it means that you are going to deal with the adrenal. And what is the age of the baby? That is less than 6 months. Like in our case, it is 2 months, and 17 OHP, whether this was near normal range, and whether it is high, so obviously this is the commonest, that is 21 hydroxylate deficiency. If 17 OHP is normal, then we have to look at what is that adrenal, how it is. So I would like to have imagine. So in this, so imagine what they have shown, that small size of adrenal, that is adrenal hypoplasia congenita, can be a common possibility, and that's one defect has also been.
So definitely, as Dr. Vijay said, that if you have primary adrenal insufficiency in the early infancy, exclude genetic causes, CAH first, then AHC. In a boy, we saw the similar case in our on-site course.
Now we move on to yes, 2-year-old boy who came with complaints of fever and failure to thrive. And during this episode, we also found to be hypoglycemic with ketones in the higher range, which was hyperketotic hypoglycemia, and electrolyte levels well returned, which showed low levels of sodium with low normal levels of potassium. And during the period of hypoglycemia and hyponatremia, the cortisol level was low, which was 112 nanomol per liter, and ACTH was there, which was more than 300, which was 1200 picogram per ml. And he was actually diagnosed and advised as a case of primary adrenal insufficiency. So do you think the diagnosis is right in this patient, the level of potassium?
Yeah. So if we analyze the case from the first, so this is a case of ketotic hypoglycemia in a 2-year-old boy with hyponatremia and normal potassium. So if the whole adrenal is gone, then aldosterone too must have gone, and our potassium will be high. But in this case, potassium is low normal. So aldosterone axis is not affected. Only cortisol axis is affected, and that's why we have low cortisol at the time of hyponatremia with high ACTH. So definitely there is some relation with the glucocorticoid axis, not the whole adrenals. So additions will be less likely rather than some deficiency of glucocorticoid, that is familial glucocorticoid deficiencies is to be considered rather than the Addison's disease as a whole.
So it was worked up, and the genetic diagnosis showed FGT1, which is the MC2 receptor, ACTH receptor problem. So the big message Dr. Ketan basically is giving is that if you have, often people say potassium is normal, it cannot be adrenal insufficiency. It would not be adrenocortical insufficiency, but it could be ACTH deficiency. It could be ACTH resistance. Even Addison's in the initial phase may have normal potassium. So just because you do have a normal potassium, don't exclude cortisol deficiency from your differential, and pigmentation in the setting such as ACTH resistance.
We had one more interesting case of a 2-year-old boy who had a history of feeding difficulty since 1 year of age, and he came with complaints of fever. And during this illness, his blood sugar was in the lower level with ketones in higher range. It was a case of ketotic hypoglycemia. And when we got the electrolytes evaluation done, and it showed sodium also was in the low range, and potassium in the low normal range, and cortisol was low for the level of hypoglycemia and hyponatremia. And on examination, the patient had pigmentation. So, is this a case of FGT1, or is it a case of Addison or primary adrenal insufficiency? Dr. James.
Continuously
levels are quite high, it is unlikely to have affection of the central axis. Remember the important differences between central hypoadrenalism and peripheral hypoadrenalism. Affection of middle axis could be in favor of primary adrenal disease. Having high ACTH levels could be in favor of the primary adrenal disease. Presence of pigmentation puts you in favor of the primary adrenal. So this type is an isolated glucocorticoid deficiency, primary adrenal disease which is evolving. Very commonly seen in conditions genetic defects of the primary adrenal gland, usually in cases of natural albinism.
There is a feeding difficulty, which is mentioned.
Because I think that is an important clue to look for possibility of activation of cardia, which can be present. So always remember these two that are because multidisciplinary assessment is very necessary that it can go over which manner, nocturnal assessment for shiftiness, etc. So this child has affection of the eyes, has affection of the gut, has affection of the adrenal. One genetic defect is responsible for all the things and cases diagnosed as Bisphosphonate.
So always look at the eyes of a child with isolated cortisol deficiency. No tears, AAA syndrome could be a possibility. Always think of it. So the key message, of course, are PI unlikely, again the same message. And look for eyes, look for feeding pattern, look for rash. These are all features of Aladdin gene defect or AAA syndrome.
So we move on to the next case. We had a 4-year-old girl who was diagnosed as hypoparathyroidism at 1 year of age. And since the last 3 years, she has been stable with her calcium levels on calcium supplementation and calcium withdrawal. During the last 3 months, she had a complaints of irritability and constipation. And during this visit, when we evaluated the calcium levels, it was found to be very high. And we also evaluated the sodium levels, which was found to be low. So what could be the reason for the high calcium level in the case of hypoparathyroidism, Dr. Ash?
So here we have a 4-year-old girl with a diagnosis of hypoparathyroidism and on treatment. So she has certain clinical features like irritability and constipation. And what is again eye-catching here is her calcium levels are pretty high, which you normally don't expect. So whenever you have this kind of spectrum where your biochemical parameters are not in sync with what the situation should have been considering the diagnosis. So always think of causes. So what can be the causes? So in presence of one like autoimmune disorder or in presence of one endocrine, always think of any comorbid condition or any co-association which might exist together. So always think of other conditions which might lead to this in presence of other endocrine organs involvement as well. Like I can say in presence of hypercalcemia, always maybe there is some underlying additional comorbidity which is correlated. Cortisol deficiency is one situation where you have calcium levels, hypercalcemia, even if it's hypoparathyroidism. This could be very well a part of like autoimmune causes.
And the typical pattern of APS, one is first hypoparathyroidism, first chronic mucocutaneous candidiasis. So look at the nails, look at the tongue, you will see candidiasis, then hypopara. 4 to 5 years, typically adrenal insufficiency will start happening. This was a typical case which progressed from there. This is he had pigmentation. Now this pigmentation was much better actually by the time he had come to us in this scenario. So key message again, if you have hypercalcemia in hypoparathyroidism unexplained, think of cortisol deficiency. Calcium normalizes with treatment, just like ABP. We said you will have masking of DI, treatment DI will reappear. This is basically a mask which has happened.
We had a 12-year-old girl who was admitted in ICU in view of meningitis. During the course of treatment, she had suddenly deteriorated and went in for shock. And during an evaluation of electrolyte, we found that the sodium was in the low range and potassium was in the higher range. And on examination, she also had a pedicle rash. So what could be the reason for the sudden deterioration? And also we found that there was a flag mark on examination. So what could be the reason for such a sudden deterioration in this case?
Thank you. So this is really a very important case, and this can be the case maybe at any point of time. You are working in ICU as well as on the stable ward. So I can see here that this is a girl who is admitted in ICU setting. She is having fever and so many things. So probably she is critically ill. And despite of in ICU care, she has sudden deterioration. And you can see here that it is going to be hyponatremia and potassium is high, that is hypokalemia. Apart from that, critical rash is there. Now, addition to that, flank mass is there. So at this point of time, I am thinking that you have to see the vital parameters and electrolytes you can see. So sudden deterioration with critical rash, flank mass. So this is probably adrenal hemorrhage. And it is going to have the acute decompensation or adrenal crisis. So here we have to really be very quick to pick up high index of suspicion, no rush to that even for say, department, radiology department to do. If bedside ultrasound is available good enough, it is not available. Even then, clinical HML as well as those electrolyte parameters are going to suffice the clinical diagnosis of adrenal crisis, and we have to manage this child.
Yesterday we had a case of pituitary apoplexy. So if you have a child with sudden shock and ophthalmoplegia, think of apoplexy. ICU child stable, sudden shock, always think of a adrenal hemorrhage, look for the abdominal, look for the flank mass. That is a big message. So of course you have to manage with fluid and hydrocort, which we all know. Give infusion of hydrocortisone after the initial bolus. Otherwise it will go in the urine. So always infusion is better, and correct that will be there. So key messages of course is shock with hyponatremia, you think of adrenal, flank mass, hemorrhage.
So we move on to the next case. We had a 12-year-old boy who was admitted in ICU where we have septic shock and multiple fluid boluses were tried and vasopressors, adrenaline, not appeared, and everything was started. But despite all the measures, there was no increase in blood pressure. So what do you like to do in this case, Dr. Chetan? And his cortisol levels will also be assessed, and it was found to be very low for the severity of shock and everything. So how do you proceed with this case?
So this is a refractory shock. So definitely, first of all, we should be looking to the sugar. If there is hypoglycemia, then definitely we need to treat first. We need to be having proper antibiotic coverage as well. And then if we look at the vasopressor, we have in form of vasopressor, we might have given dopamine, dopamine, or adrenaline, or
all of them.
All of them are continuing, and still there is no improvement as far as the blood pressure is concerned. So for this shock, this cortisol level is very low. So this looks like a cortisol deficiency in case of stress rather than no effect on vasopressor. Plus, cortisol again goes to the adrenal medulla, which will increase the endogenous this epinephrine and norepinephrine secretion. So definitely this is a catecholamine refractory shock, and hydrocortisone should be given, preferably bolus followed by the continuous infusion.
So if you have a catecholamine refractory shock, always think of cortisol deficiency. Look at cortisol. If it's less than 550, that is low. 120 is very low. So definitely you will consider, but then reassess later on. Meanwhile, also look for flank mass and all those things. It's an acute phenomena, but it is a known phenomena in that regard. We now move forward about the steroidogenic defects. So when should we suspect steroidogenic defects? If of course there's an atypical genitalia, if there is precocious puberty in boys, delayed puberty, particularly in girls, if you have a salt wasting crisis, endocrine hypertension, hypertension. So wide spectrum you have to consider. Now, if you have mineralocorticoid deficiency with androgen deficiency, so both gone, like what Dr. Subrata presented yesterday, proximal defect, star, side chain cleavage, 3 beta HSD. If you have androgen excess with mineralocorticoid deficiency, you are dealing with 21 hydroxylase, 3 beta HSD, and oxidoreductase. If you have normal, this could be an isolated aldosterone problem. If your mineralocorticoid is normal and androgen is deficient, that is 17 beta HSD, like the case Vibha was presenting, we were thinking 17 beta HSD as a possibility. Excess is aromatase. So this will be the other scenario. If you have too much of mineralocorticoid, hypertension, hypokalemia, alkalosis, your androgen is low, that is 17 hydroxylase deficiency, like the girl with primary amenorrhea who came in the onset course, who had no breast, no pubic hair, and had hypertension. That was 17 hydroxylase deficiency. Excess is 11 hydroxylase deficiency, and normal will be apparent mineralocorticoid excess, like that Sadarji whom we had seen in the onset course, who had early onset, 2 years he had stroke. So these are all, and I think all of you have seen all these cases pretty much over the last 4 or 5 days. So this is a very, very interesting use of all 5, but this is an important spectrum. So once you have a virilization, XX-TSD with hypertension, think of 11 hydroxylase, 17 hydroxyl reset XY-DSD with hypertension, 3-beta HSD salt wasting with atypical genitalia, star side chain cleavage, proximal defects, and POR is a variable phenomena in that regards. Now 17 OHP, we all get the levels done. How do you interpret? If 17 OHP is less than 300, nothing to worry. This is a normal situation. 17 OHP above 3500, very, very high, then it is most likely 21 hydroxyl. 300 to 1200, you may have other variants. So you do other workup for 11 DOC, 17 hydroxypregnenolone, and other phenomena. And 1200 to 3500, you should do a ACTH test. And then based upon the response, you will know which way you are dealing with. If it's more than 10,000, that should be less than 10,000, not 1,000. That will give you a picture. So basic basal and stimulated 17 OHP will give you a classification. What about neonatal screening? And Dr. Hemchand does neonatal screening for CAH as part of his center. That is, and he also published recently, I think, in IJP on that data. So this is one condition where you should consider. But remember, the 17 OHP using immunoassay is unreliable in the newborn period. So if level is low, unreliable means high is what unreliable. If it's low, it's low. Nothing to worry. If it is above 1200, then you should ideally do a 17 OHP via a tandem mass spectroscopy to get a structural assay. Look at electrolyte, look at genetic history. In between, again, you have to think of other possibilities, but again, confirm it once. So neonatal screening is important, but most 3 out of 4 may be normal actually. So unless a TMS has been done, 3 out of 4 will be normal. So you have to be wary about that. So we'll start with the case.
Moving on to the first case, it's respect to CAH. Here at day 1 neonate on screening, his 17 OHP was found to be very high, and we will consider this as a case of CAH and start immediately treatment with hydrocortisone, or do you like to reconfirm it again where some other method? Okay.
Whenever you look at a screening report, please look at the day of life at which the test was taken. Please look at the birth weight of the child. Please look at the gestational age, and of course the mortality of screening. Look at the units of the sample. All these parameters have to be looked into before reassuring the child that or deciding to keep the child on follow or going for an accurate testing. So once you see the second that it's a screening report, but remember it has been done on day 1. Ideal mortality of screening has been always when beyond 40 weeks and beyond. Early screening is definitely not a false positive. Some of the other fallacies also have to be documented: the prematurity, the sickness, the low birth weight. All these can influence and push up the sample. Most of the labs report sample in nanomoles per liter. Some labs report as nanograms per ml. Some labs report as nanograms per ml. So you don't have one cutoff or one number. I think that has to be factored. And other important thing is, of course, the cutoff. The cutoff, there are a lot of data that is available of what cutoff to be used. Recently in 2020, Dr. Ashima Rabasan produced the cutoff for Indian moles to be followed and published in Indian Pediatric. We have given 80, 42, and 47, I think that's cutoffs in nanomoles per liter for term, mild, preterm, and preterm babies. Of course, you have to keep in mind that multiple factors have to be kept in mind. And this lady, I think what would be prudent is to repeat the sample by TMS, and of course, it will take into consideration the day of life to be tested.
So the repeat level was normal. So highlighting that neonatal screening is just a screening. It's not a confirmatory test. Like in thyroid, you say you do a plasma sample repeat. Same thing, we should be careful. And some labs have an inbuilt way they will also do a TMS and give you as a second sort of a cascade phenomenon. They can do that. So key message is screening only after 72 hours, not in the first day. GCMS assay should be done if the EIA are high. So it could be prematurity, early samples, stress, infection, all those things can increase that. You can do it. I didn't get your point. So 1 month, 2 month child should actually have, it's too late to do a screening then they would already have developed a crisis by that time. So no point doing a screening. If you are thinking of CAH, do an actual 17 OHP rather than, now this is again what we, a lot of people, for even if you are suspecting CAH, they will do that filter paper. Filter paper is for screening. It is not for diagnosis. For diagnosis, do a proper plasma thing. Suppose you are suspecting congenital hypothyroidism in 6 weeks, you will do actual plasma value, not a filter paper sample. Same is true for this. This is for diagnosis, not screening.
We move on to the next case. We had a day 14 child who came with a concern, whose parents came with a concern of atypical genitalia. And on examination, we found that the child had bilateral gonad, and there was no uterus which was found on USG, and karyotyping was done, which was suggested of 46XY, and the child had no testosterone, and his sodium levels were found to be low with high potassium levels. So, what do you think would be the likely diagnosis in this case, Dr. Aish?
So another case which highlights the importance of a good history and examination. So if not examined properly, this child can very well pass off as a normal female. So here you can see you have clitoromegaly and you have the external sac which is not well formed. So the ASD, if not examined properly, might pass off as normal. So and you have the laboratory reports as well and the karyotype. Karyotype says it's XY, but perhaps under-verified. So there is lack of realization and the testosterone levels are very low. So as far as electrolytes are concerned, so you can see hypoadrenal, which are not have sodium on the low side and potassium on the high side. So we go to the algorithm again. So you have to check for deficiency or androgen. So as it's clear from there, you have to go for further analysis and to confirm the diagnosis, genetic analysis.
And 17 OHP was done, which was slightly elevated, and genetic diagnosis showed a 3 beta HSD.
Again, this is a table, and all of you can use both the algorithm and this table. And if you have somebody who has XY DSD with salt wasting, think of a possibility of a 3 beta HSD as a significant pathology. Now, 3 beta HSD can cause DSD in both boys as well as girls. So this is something which is there. Key messages as part of workup for DSD. So there was a yes, 14 days mini puberty has kicked in. So after 7 days, testosterone will actually be more reliable at that time. So if you have a combined androgen aldosterone deficiency, this is a proximal defect. High 17 OHP suggests 3 beta HSD. This was the grand round you presented, I think,
yes,
a few months ago.
And that was my picture.
Okay. Okay. So your hands have been immortalized now.
And we had a 3-month-old boy with concern for micropedis and inguinalia. And for the same complaint, the pediatric surgeon planning for surgery. And during the pre-anesthetic assessment, they found the sodium levels to be very low and potassium to be on the higher side. And cortisol levels were done, which was found to be low for the level of hyponatremia, and ACTH levels were done, which was high for the level of cortisol. And on examination, the child was having micropathy. So considering all the features on this side, so what could be the likely diagnosis, Dr. Vijay?
Thank you. First of all, I would like to thank the anesthesiologist that at least he has given some opportunity to look at the case in total. That it is really important before the child is going to life, we have to see in total, not just the things that we have to correct. So here we can see that sodium is low and potassium is a bit higher. Cortisol is low and that the ACTH is high. Fat circumference is 32 centimeters. So I would like to see other details of this baby. That how and one more thing that decide that look at the face of the baby, whether this is a normal looking big child or something you can make it out. Not only that micropenis part, but even if the face, if we can see it, so we can see something that is the peculiarity of the nose.
There was
and
upturned layers which were there in this case. Yeah.
Yes, thank you. So upturned layers and low set ears. So it is very important to have the clinical acumen and good clinical examination, and then we have to proceed further. So please.
Yeah. So investigations here showed the upturned layer, cholesterol level was done.
Yes. So how we are going to approach the case that we have already done the algorithm, and this is less than 6 months, 17 OH3, which is normal, and we have done that cholesterol ratio after NAS, so probability of SLO is quite high.
So this is classically Smith level optics, and that fingers are, I think, Chetan's. Chetan was there when this case was managed. So either he was taking a photograph or his hand was there in that regard. So key message is if you have microspheres, salt testing, think of Smith level optics, cholesterol level. So I will say this is a simple test. You just do lipid. If lipid is low, it is SLO. If lipid is high, it is. If you have high lipids with Dr. Santosh, no, high lipids with adrenal calcification. This was a question in the exam as well. Goldman syndrome. Yeah. So lipids are a useful thing. These are rare disorders, but you can just make based on lipid, you will get the diagnosis. So now next.
We move on to childhood cases of CAH. We had an 8-year-old boy with concerns of early puberty, and his height was relatively tall for the age, and he had a pubic hair staging of 4. And on ABG analysis, there was metabolic alkalosis, and urine chloride was very high. And based on the other features, his BP was done, which was actually high for his age and his height. So, what do you think would be the likely diagnosis in this case? The case of early puberty and hypertension and metabolic alkalosis.
And this child came from Afghanistan. And Chetan remembers this case.
So hypokalemia with metabolic alkalosis suggestive of either increased aldosterone production or increased aldosterone action. Plus, we have a high androgen driving the puberty. So we have a case of high mineralocorticoid along with the high androgens. Along with high blood pressure is suggestive of almost 11 beta hydroxy deficiency. So maybe we can see the level of DOC and then we can decide.
But the twist was that he had cryptorchidism.
Yeah.
And the child turned out to be XX. So this was an extreme virilization in an XX individual in 11 hydroxylase reared as male. And I think they had got some uterus, I think uterus was there, but they had mentioned something else. So he had come all the way and then finally we got this 11 hydroxylase. The karyotype was given as XY. Given as XY in Iraq or I don't know, Afghanistan.
Iraq, there was war going on and all. And this boy was taken for surgery for undescended testes and they have found few other things rather than undescended testes. So they have again closed the operation at 1 year of age. And the father didn't show to any endocrinologist in Iraq. And then boy continued to rear as male. Then he started growing hairs all over the face and legs and all. And then they came here at 5 to 6 years of age.
So this was a very sad scenario, and often they can come with hematuria. We have seen patients with CAH who are reared as male, no simple virilizing form, they present with hematuria. Now, what is this hematuria? These are menstruation. So they will have cyclical hematuria. So blood pressure becomes very important in precocious puberty. That is one message. You will then identify, and they will be reared as male, and they are happy with this. So again, if you have hypertension and precocious puberty, think of 11 hydroxylase deficiency. That will be the key message from there.
I guess myself and Chetan sir are taking turns. This is the case I presented. So 14-year-old girl who presented with concern for delayed puberty and height was normal for the age and with breast staging of 1 and pubic hair staging of 1 and height was actually taller for the level of pubertal status and on
she was taller than all of us.
And on ABG she had metabolic alkalosis and his hypertension was found 2 to 3 letters after the diagnosis of delayed puberty. Despite 3 or 4 medications, BP was not under control. So, what could be the cause in this case, Dr. Hanson?
This case would be a converse of the previous case. I think the writing is on the wall. A significant hypertension requiring more than 3 drugs, presence of hypokalemia, presence of alkalosis. All this suggests that this child has mineralocorticoid excess. So, we are looking at a child who has mineralocorticoid excess. But if the child is not progressing in terms of puberty, this child has probably a deficiency of androgen. And this child probably a careful physical examination reveals that this child has a palpable gonad gonads were involved in it. So as these gonads were not functioning, so they were not able to produce androgen, so there was androgenic deficiency. And so this presented as a girl with delayed puberty. So I think the message from this case is measurement of hypertension is pivotal in every child with delayed puberty, and hypertension, hypokalemia, and alkalosis, medullary excess, whenever you have hypertension and you have a delayed puberty, it's very important that you can keep 17 alpha hydroxy.
So there's an old dictum, old pediatric endocrine books used to say sexual infantilism in a girl with hypertension. That is 17 hydroxylase deficiency. And that Turner syndrome, mild hypertension, renal failure, mild hypertension, severe hypertension, no breast, no pubic hair, 17 hydroxylase. And you saw the girl who was actually a girl. This was the XY. This was the earlier case. So we have seen that XY DSD who presented with that phenomena. So key messages: delayed puberty plus hypertension is 17 hydroxylase. XY DSD with gonads will be the scenario. So I think I'll just touch base on the management and we'll stop because there are other sessions to go. We already covered a lot of ground in terms of adrenal. So when we manage 21 hydroxylase deficiency, the key is to give hydrocortisone, that too at the right dose and the right formulation. So growing children, only hydrocortisone. Typically, a maintenance dose around 12 to 15 will be required. If you give that, your testosterone will come down. You have to give fludrocortisone even if it is a simple virilizing form, because there is a covert aldosterone deficiency. If you have aldosterone deficiency, you will have hypovolemia, ABP will go up and your requirement goes up. So if you are giving less fludrocord, your hydrocord requirement goes up. So both are very, very important in that scenario. Often once you start treatment, you will trigger a central precocious puberty. As Dr. Hemchand was talking about aromatase inhibitors, it's an experimental situation also you can theoretically think of. GnRH analog, invariably, in my experience, nearly everybody who is a peripheral precocious puberty will trigger central, and they would need on that a GnRH analog in that scenario, and often GH, as well. And one of our patients are being managed, both are together, is on the similar situation. So generally, hydrocortisone is a drug of choice. Neonates, you can use a higher dose, then your dose can come down. Fludrocortisone neonates require a higher dose, 0.2 milligrams, because their salt intake is less, their tubules are not well, and it may be stopped rarely in elderly, in adolescents. Salt intake. If you don't give salt, your aldosterone is not going to act. The aldosterone is only increasing the amount of salt that is being absorbed. Zero salt, zero absorption. So in infants who have less salt in their diet, you should give them salt, which is important in that scenario. Monitoring is largely clinical, biochemical, not much told in terms of 17 OHP. So if your 17 OHP is low and bone age is low, you are over treating. If your 17 OHP is more than 1200, then you probably are under treating, and that becomes important. So I think this was a very interesting session on adrenals and grand round. So I'll thank all of you. Thank Dr. Naveen, Dr. Chetan, Dr. Vijay, Dr. Aisha, and Dr. Hemchand for this wonderful interaction. And we will close this session and we'll move forward to the next session, which would be about the state of the art. So this session is mainly about how things are progressing in terms of the development, and that regards. If there are any questions, we can quickly take on to that. What are the DHES cutoff would you evaluate for non-classical CH in the setting of premature adrenarche, and it is universal for any age group? So if it's more than, I would say 150 and above in the pre-pubertal age group, I will get worried. More than 200, really worried. That will be the sort of cutoff Dr. Satyakala will take on that. So thanks all of you for being part of this program. And we'll now move forward towards the last session, which is the state-of-the-art session. So we have got 4 very interesting talks, and these are going to be very crisp talks on specific topics in that regard. Dr. Hemchand is the chairperson for this, so you can stay here. That will be very helpful. So we'll have the first presentation is from Dr. Vijay, and I'm just downloading his presentation. So his talk is about what's new in terms of thyroid, and that is very, very relevant from that perspective. And these are going to be sessions which are like directly on point. What's new? We all know basics of everything. We just want specific informations in that regard. So we'll start off with Dr. Vijay. Our aim is to cover so that we are abreast of latest developments in that scenario. So Dr. Vijay, please. Dr. Vijay is an old friend and colleague. He is been with me for now, I think 14 years or so. And he is currently working as a head of department of pediatrics and a very dedicated person in pediatric endocrinology, trained under Dr. Vaman. And now at Meerut, he is just doing a great job in terms of spreading pediatric endocrinology.
Thank you, sir. Thank you. First of all, a big round of applause to Dr. Anurag, sir, and the hard-working team, and of course, the learned audience. Why I'm saying this thing that it is not easy to stick with chairs for endocrine setup for last 3 or couple of more days. So the topic given to me is really like putting an ocean in a small pot. That yearly review for thyroid. Actually, it is a very big topic. So what I have tried to concise that what are the various avenues where we are going to act upon? What are the various thought process that in coming years probably still they are unsolved puzzle. Probably we are going to get answer for the same. And what I have divided in 2 parts, that is particularly that is in neonatal or say congenital hypothyroidism. What new? And the second, that is thyroid excess, that is thyrotoxicosis, Graves' disease. What are the newer abnormalities? Just I'm going to talk about that. First, that it is really very important that we do correlate that mental retardation or neurodevelopmental delay with maternal level of thyroid and iodine. So, is there really association between maternal urinary iodine assessment, dietary iodine intake, neurodevelopmental outcome in the child? And this was a very important systemic review I came across, and they have done with the. So what they have concluded after so many searches, and the net conclusion that the majority of the studies classified pregnant women to be mild to moderately iodine deficient based on urinary iodine assessment with subsequent offspring neurodevelopmental implication, whether this is there or not. So what this review suggests that dietary intake data may indicate a stronger association with cognitive outcome than urinary iodine measurement alone. So it means that we have again back to basic, that we have created a good history in terms of even what is the intake. So what is the strength of this review? That it distinguishes results based on cognitive outcome per urinary assessment with dietary data. So still, this is not a very robust, so we can't say that yes, it is, but yes, it sensitizes us that future work is needed respecting the usefulness of urinary iodine assessment as an indicator of deficiency, whilst also taking account of dietary intakes. Now, second is that one more thing, that it is not easy to manage Hashimoto's thyroiditis, and is there any new or some additional drugs you can add for better management of Hashimoto's thyroiditis? So this is a very common autoimmune disease characterized by high level of thyroid peroxidase antibodies and thyroglobulin antibodies, as well as infiltration of lymphocyte in thyroid. So that's why you are going to have a formed thyroid during palpation. In recent year, metformin is not only, you can say that ये diabetes की drug नहीं है, it is having so many implications. So what they have proven that effective in a variety of autoimmune disease, that is SLE, rheumatoid arthritis, multiple sclerosis too. So what in this study systematically explored the therapeutic effect of metformin on Hashimoto's thyroiditis and its underlying mechanism, that how it is going to help. And they have done a very robust study. They have used animal model in vitro, cell culture, differentiation, mRNA sequencing, and what they found that metformin indeed had a therapeutic effect on mice with this osteomatrothyroiditis, mainly by reducing thyroglobulin antibody and lymphocytic infiltration in thyroid. In addition, metformin also significantly suppressed the number and function of T17 cells and macrophages polarization. One more thing, that how it is going to act. So mainly they have postulated that it is going to act on by regulating immune pathway. The third, a very important, interesting, that people are consuming so many things. We are doing day in and day out these thyroid function tests, and thanks to wellness checkup, that is annual checkup, जो अभी पैकेज में आता है वो from various pathologists. So what they have tried to do that, well, what are the effects of micronutrients on thyroid parameters? So micronutrients are involved in various vital cellular metabolic process, including thyroid hormone metabolism. So correlation between serum level of micronutrients and their effect on thyroid parameters. So they have seen all the thyroid markers, and what they have found, that deficiency of vitamin B2, B12, B9, and 25-hydroxy vitamin D is significantly affecting the thyroid functioning. One more important, that amino acid, that is asparagine and serine, were found to have a strong positive correlation with TSH. Yes. So it is really important. One more study I have came across, that we very frequently use this. Rather, this is the first line of management if we are going to manage a case of thyrotoxicosis. So what's new? And why I have put this, that first we have to understand that what is the difference between a young patient presenting with Graves' disease versus late presentation of Graves' disease. So younger the patient tend to have more severe hyperthyroidism at presentation when compared to adults. And this is may be partly related to the nature of the underlying immune dysfunction. Why this study? That at least we have to prognosticate that how this patient or this big chunk of patients are going to respond with this simple drug or some more medication or some other modalities of treatment may be required later on. So recent data have shown that HLA complex 5 P5 polymorphism is independently associated with Graves' disease susceptibility and age of onset. So it means that we don't have to only work out for the thyroid function, but to predict that how this child is going to be in future management, probably we have to take the help of our geneticists also. This is a very beautiful paper what I came across, that randomized trial of block and replacement versus dose titration dynamite in young people with thyroid. A very long debatable topic. कौन सा ठीक है, कौन सा नहीं ठीक है, इसका कॉस्ट इफेक्टिवनेस किसका है, किसका कॉस्ट इफेक्टिवनेस नहीं है. So keeping in mind that what we expect as endocrinologists, so we thought that, all the people thought that, expectation was that biochemical control might be better with individuals on block and replacement therapy, which was not observed with this paper. So while the study was underpowered, the likelihood of beneficial effect of block and replacement on biochemical control being overlooked because of this was remote, and there were more adverse events in block and replacement group. So I'll show the figure in next slide, that what is the distribution of TSH in patient from trial. And what it's shown that no meaningful improvement in biochemical control on block and replacement therapy in most patients. So you can see here that randomized trial of block and replacement versus titration. So proportion of PSS value within normal range. So it shows that no significant difference. And of course, if we are going to restrict with titration therapy, probability of lesser side effect in comparison to block and replacement therapy. But again, this is not the whole story. So what next? Here you can see with the same corollary that severe Graves' disease ultimately resulted in a change from daily to this high dose regime comprising a larger dosage of carbimazole as a part of this block and replacement regime. So this is the candidate that once the disease is severe, probably you are going to do the same, that you are going to increase the dose and probability of this block and replacement therapy is there. But of course, as a general rule, probably we have to stick on titration regime, that is DT regime. This is good. Now the third question is that going to stop. So if the patient is euthyroid at the end of 12 months, then the likelihood of relapse is small and thyroid status can be less frequent. What next? That if the patient is euthyroid 2 years after stopping anti-thyroid drug, then it is feasible to discharge the patient back to general practitioner, though blood still needs to be checked on annual basis. Not only for recurrence, that is Graves' disease, but rather hypothyroidism too. So that is really important to look upon. This paper, I really request all of you to go through this, that this is going to set up a number of things that so alternative strategies, what can be the alternative strategy? So one future area of research in this thyroid management is to focus in greater detail on patients with more severe disease who are less likely to respond to anti-thyroid drug in long term. So perhaps these patients may ultimately benefit from newer immunomodulatory strategy such as biologics, TSH receptor antibody and peptide therapy. So where they are going to act upon? So new therapeutic horizons for Graves' hypothyroidism, that is a group of drugs that is rituximab, which has been very frequently used in so many conditions. So how they are going to have to act, that is beta lymphocyte immunomodulation. That is one approach. The second approach can be the drugs which can, that is neonatal FC receptor blockade, and they are going to block immunoglobulin recycling. The third group, that is TSH receptor signaling drug, they are going to block this, and the fourth, that is immunomodulation, that is on the TSH receptor peptide, that is immunotolerance. So these are the future that how we are going to act upon. But still, with the available study and data, these drugs are not alone sufficient to have cure or remission for thyrotoxicosis. So in nutshell, how we are going to, what is the future, that is relationship between what we have to again explore, that is relationship between autoimmune thyroid disorder duration beyond 5 years and likelihood of relapse needs to establish in greater detail. The baseline immune and genetic factor that may impact on likelihood of remission need to be explored in more detail. This may help to predict outcome. Patient can potentially be stratified as low or high risk of an adverse reaction to anti-thyroid drugs, including agranulocytosis with associated alteration in surveillance program. The potential role of long-term iodine therapy needs to be explored in more detail. the role of existing and novel immunomodulatory agents still need to be explored. And long-term, this carbimazole therapy in excess of 3 years duration is still a realistic option for young patients with Graves' disease who are at high risk of relapse. Data from randomized trial indicates that this titration therapy is associated with similar biochemical control when compared to block and replacement therapy. Yes, one more thing, that what we expect in thyrotoxicosis, that abhi weight gain uska theek hona chahiye, but how weight gain can be a major problem in patient with Graves' disease starting this anti-thyroid treatment. Not only that this drug, but rather if these patients are going to have hypothyroidism, probably it is going to increase much. Patient in remission following anti-thyroid drug need monitoring because of the potential for autoimmune hypothyroidism as well as relapse. Because if you are going to test not with thyrotoxicosis, not only the jab antibodies, but rather they are going to have infiltration and probably they are going to have positive antibody for anti-T2 and anti-thyroglobulin. So this patient, that is once it was a patient of thyrotoxicosis, later on over a period of time they can have a frank-blown case of hypothyroidism. So these are the literature what I have came across. So thank you so much.
It was a wonderful talk. Thank you.
Thank you. And these are the suggested reading and references. Thank you.
And we will share the references to the one you shared to me and share to everybody.
Yes, yes.
Wonderful talk.
Thank you.
Especially with Graves, a lot of new things are happening. We think thyroid is always the same, but we are seeing so many new things happening.
That is not the same.
So now we will move forward to the second talk. I'll request the speakers because we have to probably close the session positively by 12:30. That is the aim, so that people have to leave also. So we'll now request Dr. Vikrant to talk about CAH, especially like Dr. Vijay talked about very brilliantly about what's new. So what's really new in terms of the CAH, and Dr. Vikrant, as we already introduced, is working as a pediatric endocrinologist in Lucknow. He runs the Endocrine clinic, and he is also part of the medical college there. Which medical college?
Integral Institute of Medical Sciences and Research.
Integral Institute. So over to you, Dr. Vikrant, and we will love to hear from you about what more we need to learn. We already discussed in the grand round, but what is new which you would like to add to that? Thank you.
So a very good morning to all of you. I really thank, and it's really privileged to be a part of this program today. So as during the last couple of days, you have covered a lot about adrenal pathophysiology, diseases affecting adrenal glands, congenital adrenal hyperplasia. So we are going to discuss a bit more in a refined manner according to the latest guidelines that have been introduced. So first of all, we will start from the newborn screening. So newborn screening has now become an integral part, and screening for congenital adrenal hyperplasia in particular, it should be done for each and every child. So previously the assays which used to be a part of these screening programs, they were radioimmunoassays, and they were really affected by a lot of parameters like steroid metabolites in the newborn age. So they have been replaced by Delphi assays. Now most of the labs they are using them, and in particular, it is very difficult with the standard of care is LCTMS, as sir has already discussed. So the first year investigation, the first year screen test should be Delphi assays, and if they are coming positive on them, that should be tested further with LCTMS. If we talk about the cutoff of screening, so there are a lot of confounding factors that affect the 17 OHP levels in congenital adrenal hyperplasia, like prematurity, like sickness. So different cutoffs have been designed, as Dr. Hemchand has talked about. Asima, Dabas and et al. They have come out with newer cutoffs. So we have to take that cutoffs in view of the weight age, in view of the weights and the gestational age. Now the recommendations are those cutoffs should be taken in cognizance with the gestational age of the patient. And one thing more, we should be very particular about the units that have been used. The most of the units that we are talking about are here in nanograms per deciliter, nanograms per milliliters, and nanomole per liter. So we should be very particular in what context of units we are interpreting the data. Now, as far as the
which slide?
Sir, actually, I was at the second slide. So actually here I would like to state that congenital adrenal hyperplasia is a lifelong disorder. And once you have stamped a child with classical congenital adrenal hyperplasia, then the treatment has to be continued for lifelong. So one thing should be remembered, that it should be with a proper diagnosis. So if the diagnosis, the screening has not been done with the help of LC-TMS, then it should be confirmed either with the post-syntropic stimulation test or with the genetic studies. Now, as far as the treatment of classical congenital adrenal hyperplasia is concerned, we all know that hydrocortisone is the mainstay of the treatment in pediatric population. There are other forms of steroids also available, like long-acting synthetic forms like prednisolone, dexamethasone, that are used quite rampantly in adults. But we should refrain from using them because they have a growth suppression effect, and as a result, hydrocortisone should be effective. It can be crushed and mixed with milk or liquid as such, and the dissolved part that should not be used. So it has been seen that the young patients with congenital adrenal hyperplasia who were administered prednisolone, they had less separation in the morning 17 OHP levels and short adult height, suggesting overdosing and the poor clinical response. So hydrocortisone should be administered in the physiological doses of 10 to 15 milligram per meter square during infancy. So doses of hydrocortisone have been chosen regarding the normal physiological endogenous production of cortisol. So the dexamethasone and prednisolone, they have been reserved for post-pubertal patients. There was a drug, actually with this hydrocortisone doses, we are not able to simulate the normal physiological rhythm of the cortisol that is being secreted. So as a result, the suppression of endogenous is not very remarkable, and it is something far from the best results. So there are other forms that have been tried, like Tronocort has come into market, that is a dual release preparation. It consists of the immediate release layer and a layer that is delayed release preparation. So that has been those capsules have been marketed for use in children 12 years and above. They have come out with the name of F-MODI. So, but they are only useful only in the post-pubertal patient. Not many studies have been conducted in the pediatric population. As such, we can recommend them to use for regular users. There was a preparation which were sprinkles of hydrocortisone, Alkindi. So they used to come in the strengths of 0.5 milligrams, 1 milligrams, 2 milligrams. So they could be directly taken into the mouth, or they could be mixed with some of the food particles, but the results were not very astounding. But these are some of the advances that have been made in the preparation. The other thing, some studies tried to give subcutaneous infusion of hydrocortisone to simulate the circadian rhythm, to simulate the normal physiological profile, but they also had got some skin irritation and other effects. So at the moment, we cannot recommend them for normal practices, but we should know ki Alkindi, F-MODI, these are some of the advances that have been made as far as the treatment portion is concerned. So now there have been some controversies regarding hydrocortisone should be supplemented in 2 doses or a 3-dose schedule. So the best of now is the 3-dose schedule. The morning dose can be given as early as possible in the morning. Normally
And the maximum suppression of adrenal hormones it takes after 2 to 4 hours of administration of morning or afternoon dose until 6 to 8 hours of the evening dose of the hydrocortisone. So best time to administer hydrocortisone to achieve adrenal suppression is the morning, which corresponds to the circadian rhythm. So there were in the past there came a hydrocortisone cypionate suspension in the market. So actually the results were not very astounding with those, because the delivery we couldn't be sure of the doses that we were taking in the form of suspensions. So that was also taken away from the market. So as of now, modified and extended release preparation, FMOD, they cannot be recommended for use, and these preparations are advisable only for 12 years and older children. Now this stress dose has already been much stressed. So congenital adrenal hyperplasia patients, they are not able to mount the adrenal response that is required in the times of stress. So adrenal, these stress dosings are an integral part of the management of congenital adrenal hyperplasia. The child should be told that during the time of stress, the doses have to be tripled or to 5 times or so to stimulate the, to counter effect the, so that we may not face the adrenal crisis during the times of stress. All the patients of congenital adrenal hyperplasia should be higher doses of hydrocortisone. And when we give doses more than 50 to 75 milligram per day, per meter square per day, there is no need to add fludrocortisone, because it already has got a mineralocorticoid effect, and that can be taken care of. Once the stress subsides, then you can go back to the normal doses which were used, normal physiological doses. So management, we all of us know adrenal crisis, but I would like to share an experience of mine. One of the patient collapsed. We gave the stress dose in the form of intravenous form. So actually Raghupati sir used to say that it is better if you administer it in the form of intramuscular, so that it tends to act a bit longer to protect the adrenal crisis. Infusion is better. What sir has told, that will be the most desirable thing. So there is no controversy regarding the whether fludrocortisone should be given or not in all cases of congenital, in classic congenital adrenal hyperplasia, whether they are having overt deficiency of mineralocorticoid or not. Fludrocortisone should be given, because that takes part of the hypovolemic. Even if the electrolytes are within normal range, we have to gauge through the plasma renin activity. That has to be kept to 2 to 3 times of normal, so that the doses of glucocorticoid can be kept normal. So this higher doses of fludrocortisone, they carry the risk of hypertension, edema, they have to be looked for. So a recent study reported similar dose requirement for fludrocortisone and hydrocortisone. The height SDS and BMI SDS is salt supplemented and unsupplemented, questioning the role of regular supplementation in congenital adrenal hyperplasia. Sir, we have never used salt in newborn age, and luckily or so, whatever might be the reason, we have never encountered such a problem that the patient went into adrenal crisis. But of now, the studies say it should be given, and as you have given the plausible reason for it, when there is no salt, how the fludrocortisone is going to act? Some sort, and that is ascribed to the renal immaturity in infancy. And one thing more, the doses of fludrocortisone can be tapered with time. The mineralocorticoid requirement, it decreases with time. So during adult life or after post-pubertal area, sometimes it can be weaned off totally. Now a few words about non-classical CAH. In children and adolescents with early onset and rapid progression of bone age and overt virilization, glucocorticoid treatment should be given. This is the only indication in non-classical congenital adrenal hyperplasia when the bone age is severely advanced. Then and only we should use glucocorticoids. In asymptomatic non-pregnant individuals with non-congenital congenital adrenal hyperplasia, glucocorticoid treatment is not recommended. In previously treated patients with non-classical congenital adrenal hyperplasia, glucocorticoid treatment can be discontinued when the adult diet or the symptoms resolve. In particular, the women who are desiring pregnancy and who are suffering from infertility, they should be offered, even the non-classical congenital adrenal hyperplasia cases, they should be offered glucocorticoid treatment. Stress doses should be given or not given. This is a controversy. So now the latest guidelines, 216 Endocrine Society guideline, they say stress doses are to be given only when there is iatrogenic adrenal suppression or the post-entropin stimulation test says that the results are subnormal, less than 14 to 18 microgram per deciliter. So the gist of the matter is non-classical congenital adrenal hyperplasia. It doesn't require treatment until and unless there is overt virilization or there is advancement, undue advancement of bone age, or in infertility cases, we can use it. So now the monitoring. Now the monitoring part, classically we have used 17-hydroxyprogesterone, plasma renin activity, and adrenoendostenedione. So what levels should be achieved? The 17-OHP levels should be capped up to 2 to 3 times the normal, and ACTH levels also. ACTH and serum cortisol levels should not be used for the monitoring of patients with congenital adrenal hyperplasia. Like because of some problem with the circadian rhythmicity of endostenedione and other metabolites, some 11 deoxygenated steroid levels are being checked, and in adult population, they seem to give a better results. So in poorly controlled cases of congenital adrenal hyperplasia, we may resort to newer 11-deoxycortisol and other measurements in blood. So one more contentious thing is the timing of genital surgery. So genital surgery should be early genital surgery during infancy is recommended for severely virilized individuals, only who have got predator staging 3 or more. There is evidence to show that there may be partial regression of the mild clitoromegaly after starting hydrocortisone replacement, thus averting the need for extensive surgical correction. And now what surgery should be contemplated with? It is clitoroplasty. Vaginoplasty can be left for a later date, because if we are contemplating with vaginoplasty earlier during 6 to 12 months of age, at the time when we are doing clitoroplasty, we may need to do repeated episodes of vaginoplasty later during the time when the after and post-pubertal age. So corrective surgery is indicated when the patient has a high proximal junction between urethra and the vagina, and it includes vaginoplasty, clitoroplasty, and labial surgery. Most of the children will need a raised stage repair. Now, there comes a role of bilateral adrenalectomy. There are some patients who respond very poorly, and we are not able to control the androgens in those patients. So there comes the role of why not we remove the adrenal gland from the body, so that the source of the androgen production is removed and the matter is solved. No, there are other pathways which are acting in the body that can lead, and it can also have some detrimental effects in the form of Nelson syndrome, because ACTH driven effect will be there, and that will lead to Nelson syndrome. So as of now, bilateral adrenalectomy is only in experimental regimes. It cannot be recommended as of now. So what is the role of prenatal dexamethasone therapy? In short, we do not recommend it. We do not recommend it in normal practice, because we know the chances of having a defective child is 1:4, and out of them there is only 50% chances of being a female. So there are only 1:8% chances of being a female with a child, because it only prevents virilization and it is not going to ameliorate the basic pathophysiology. So refrain from using outside the experimental, outside the protocols. So the criteria though. Now the gender assignment should be done after expert opinion. Most of the congenital adrenal hyperplasia cases with XX DSD, they should be assigned female role. Only in some of the cases where the virilization is very severe, the penile length is quite more, and it looks like a male, and because of the bombardment of the androgen, the child himself, his gender identity is male, he thinks himself to be male, we can very rarely assign a male gender, and there we have to do hysterectomy and all those procedures. So a recent review of 52 cases of CAH from India reported male gender assignment in 1/4 of simple virilizing cases, like the case I have just talked about. There is similar data from northern India which showed male gender assignment in 35% of the cases affected girls. So in all patients, gender identity is generally male and fertility is possible. So for possible, we do a oocyte retrieval and other things that can be preserved, and later on the child in later ages of life, he can contemplate to have a child. Thank you.
Thank you, Dr. Vikrant, for a very nice summary of the entire topic. And while we are loading the next presentation, I'd like to have comments from Dr. Hemchand about these new developments.
Thank you. I just want to say 2 points. Number one, there is a thing in our particular case, genital surgery for teenagers. The genital surgery has been banned. So I think it is preferred that genital surgery in teenage is postponed till the patient themselves can be given, can be able to participate and give a consent. So this is the government guideline which we are expected to follow. Analogous to what is there in the West Nigeria, that was something we did. And second thing is regarding sex assignment, it's always better to have a multidisciplinary team putting your setup and a team decision regarding sex assignment, putting in perspective the pros and cons, be presented in front of them rather than individual doctors take the decision. Practically, it's very difficult to create a multidisciplinary arrangement to all come together. But I think it's very important in the future medical legal perspective that we have a team set up in our place so that we give them a proper. Nice talk summarizing all the practical aspects of management and development.
So I'll now have the pleasure to invite Dr. Neha Agarwal. Dr. Neha gave a very good talk on DEXA assessment yesterday, and she's going to touch base very briefly about low bone mass treatment. Since we are having very limited time, maybe we'll have 10 minutes each for both Dr. Neha and Dr. Chetan so that we have an overview, because everybody knows about most of the things. We just want to go through what's new in terms of therapeutics for low bone.
A very warm good evening, everyone. So in the next 10 minutes, we'll be touch basing the topic in pediatric osteoporosis. Till now, we have been thinking that osteoporosis is a disease of adults, and we generally do not encounter this condition in pediatrics. But to our amaze, it is also a pediatric condition, but it differs from adults not only in the management, but also in the definition and diagnostic modalities. So before moving ahead with the latest therapeutics in the management of low bone mass in pediatrics, the first question that arises is who are the actual candidates who need this treatment? So International Society of Clinical Densitometry has very clearly pointed out in the year 2013 that all those children who have vertebral compression fracture with or without a BMD Z score of less than -2, and yesterday we all have gone in detail about the BMD Z scores, or a BMD Z score less than -2 with a history of long bone fracture. In this long bone fracture, there should be a frequency of more than 2 long bone fractures in a child less than 10 years of age and more than 3 long bone fractures in a child less than 18 years of age. So if you have a vertebral compression fracture, that alone is sufficient to start therapy in such a child. But if you have a low BMD Z score, then a clinical history of pathological fracture is important. So why does this low bone mass occur in individuals or children? So yesterday we have gone through this variation in the bone mineral density across the lifespan. And if we further dissect the first 20 years of life, then what we analyze that the peak height velocity is attained nearly a couple of years prior to the peak bone mineral density. So what does that mean clinically? That during the adolescent or the pubertal phase, although the bones are elongating, but they are not accruating the bone mineral density. So you have longer but weaker bones. And such children are at higher risk of pathological fractures. And studies have found that adolescent males are at a higher risk of fracture as compared to adolescent females. And this could be attributed to their general intensity of going out, being physically active, or having a low estrogen level as compared to the females. Apart from this adolescent phase of low bone mass, there are a number of primary and secondary acquired conditions which are responsible for decreasing the bone mineral density. And all these conditions directly or indirectly cause an alteration in the bone remodeling process, which you would have already studied in the bone physiology class. So these conditions lead to an increase in bone resorption compared to bone formation, leading to a decrease in bone mineral density. So taking advantage of this physiology, the available therapeutic options which are available fall into three categories, which are anti-resorptive, among which we have bisphosphonates as the prototype of being anti-resorptive agents, followed by SERMs, calcitonin, denosumab. The second category is anabolics or the bone-forming agents, among which the recombinant parathyroid hormone is the prototype. And there is a new class of drug coming up, which is a sclerostin inhibitor or the romosozumab, which has a dual action. But what is surprising is that none of these agents are approved by FDA for use in pediatric osteoporosis. So what do we do next? So these are the latest guidelines which are published in pediatric rheumatology in the year 2020 for the diagnosis, assessment, management, and monitoring of pediatric osteoporosis, which tells us that calcium and vitamin D supplementation form the backbone of managing pediatric osteoporosis. And although FDA does not recommend use of bisphosphonate, but bisphosphonates can be used because for the last 30 years, we have experience in using bisphosphonate for pediatric osteoporosis without any long-term side effects. So our talk will be focused on bisphosphonates because these are the therapies which are recommended or which are in constant use in pediatrics. So bisphosphonate are basically pyrophosphate analogs, and among this, what we see in the molecule is that the phosphate carbon phosphate lineage is responsible for the affinity to the bone tissues. So there are two side chains, the R1 and the R2, and this is the R1 which is responsible for the affinity to bone tissue, while the R2 is responsible for categorizing bisphosphonate into nitrogenous bisphosphonate or the non-nitrogenous. Both the categories ultimately lead to apoptosis of osteoclast, which is the main cell type responsible for resorption. They have a fundamental difference in the mechanism of action. So generalizing, we have bisphosphonate acting as the anti-resorptive agents which bind to hydroxyapatite crystals in bone, directly or indirectly inhibit the osteoclast. And they are pharmacologically active only on the exposed bone surface, and they are bound to the bone for years to come. So, but this anti-resorptive property of bisphosphonate could not explain the fracture rate incidence which was getting reduced in using bisphosphonate. So studies were done to further elucidate the mechanism of action of bisphosphonate, and it was found that along with the anti-resorptive decreasing capacity, bisphosphonate also potentiated the life of osteoblast and osteocytes. Osteocyte, as we know, are the mature osteoblasts. So this property was responsible for causing a reduction in the fracture rate in children who were treated on bisphosphonate. So this graph shows a general relative resorptive potency among the older and the newer generation bisphosphonate, and it can be clearly seen that zoledronic acid, which is a newer agent, has comparatively better anti-resorptive potency as compared to the older molecules, which is etidronate or pamidronate. Coming on to now, we know that bisphosphonate are the agents of choice to be used in pediatrics. The next question that arises is what dose should be used, how frequently we should use. But as I told, there are no FDA recommendations for the use of bisphosphonate, so we do not have any recommendations on the dosing as well. But because of the studies that have been conducted across the world, these are the general doses that we follow. So these are easily available in the Pediatric Rheumatology 2020 guidelines, so we'll not spend much time going through this crowded table. Next, we will come that there are two routes of administration of bisphosphonate, oral versus intravenous. So once we have decided that we have to use bisphosphonate, the next question comes is, should we go for oral or intravenous? So this was a Cochrane study which was published around 5 years back in 2016. It included 14 trials with 819 participants, but among these 14 trials, only 4 trials had a head-to-head comparison of oral versus IV bisphosphonate. And although we have a limited data, it showed that there was no difference in the acquisition or improvement in BMD among the oral or the intravenous bisphosphonate. But because the experience is more with IV bisphosphonate among children, so it is preferred to use IV in children The only indication for using oral is mild osteoporosis with no vertebral fractures, or if there is a clear-cut contraindication for using IV bisphosphonate. So just to break the monotony, these are some radiological images acquired from children who are on bisphosphonate therapy. So you can see on the radiological images, there are some sclerotic bands present in the metaphyseal regions, and these are known as the zebra lines. These are the periods of inhibited osteoclast activity during the growth phase. They have no negative effect on the growth potential of the child, and they disappear as the bone moves towards the diaphysis. So how long to give the therapy? So ideally speaking, again, there are no set recommendations of how long to use, but as a thumb rule, it should be used till the BMD Z score improves above -2. So no drug is associated without adverse effects. So bisphosphonate is also associated with some acute and long-term complications. So among the acute adverse effects, we have the flu-like illness, which can be avoided by giving either a paracetamol 24 hours before or covering paracetamol infusion 24 to 48 hours after bisphosphonate. Then we have the risk of hypocalcemia, which can be decreased if we maintain a sufficient vitamin D level above 50 nanomoles or less than 30 nanograms. And then there are long-term side effects of osteonecrosis of jaw and atypical femur fracture, although no pediatric cases have been reported so far. There were some doubts regarding atypical femoral fracture in bisphosphonate treated patients among osteogenesis imperfecta, but studies have clearly found that it was not due to the usage of bisphosphonate, but was due to the underlying OI severity. So should we use bisphosphonate routinely was the next question that was answered beautifully by this study. We stated that it needs to be assessed on the basis of the underlying clinical condition leading to the low bone mass. So if we have a condition which is of transient and it has an increased chances of recovery of low bone mass, and one can wait for BP therapy. But if there is a permanent condition like a neuromuscular disorder in which there is no chance of increase in LBM, then one needs to counsel the patient for BP therapy. The other molecule in pipeline is the rank ligand inhibitor, but because we are not using it routinely, so we will not spend much time on this. Just to touch base, it is a rank ligand inhibitor. It also inhibits bone resorption. It has to be used for a period of 2 years. The dosage are 60 to 120 mg administered subcutaneously 6 monthly. The available brands are Prolia and Extiva. It has a rebound bone resorption once the molecule is stopped, and thereby there is a risk of hypercalcemia and hypercalciuria. Because there are no long-term studies using this molecule, so pediatric usage is limited. So there are isolated case reports using denosumab, which have shown that the usage beyond 2 years have no improvement in BMD. So usage till 2 years is recommended, and after which bisphosphonate therapy should be used to avoid rebound resorption. So after these are the available literature. Anabolic agents are still in pipeline, not much recommended. PTH hormone, although used in adults, is associated with risk of osteosarcoma in children because of the growth potential. So these are also not used. Anti-sclerostin molecule is under trial. There are some clinical studies going on. So maybe in the next session we can have a look on it. So take home messages from this slide is that calcium vitamin D supplementation is still the backbone of low bone mass therapy in children. Bisphosphonate should be used only when clinically indicated, and routine clinical, radiological, and analytical monitoring should be done along with BP therapy. So these are the papers which you can use for further reading if interested. Thank you.
Thanks, Neha, for really summarizing in just 10 minutes. It was a very long topic and we had to rush because the final presentation is coming and we like to finish by 12:30. We'll have a detailed one probably on an online session we can have on more detail on the same topic. So now we have got the final talk coming and on a very important topic, which is basically about the role of GnRH analog. So we'll specifically be focusing on what are the newer guidelines about when to use, how to use, and how do we go forward from there. So Dr. Chetan will be talking about. So we all know about physiology and all those things. So we'll basically probably start off directly. So we'll be discussing about the nuts and bolts, primarily about GnRH therapy. And we've got only 10 minutes, so we'll try to focus. Otherwise, your flight will be lost. And probably the hotel people are also wanting to ask, otherwise they'll evict us. So anyhow, it's been a wonderful discussion and we've covered so many topics. And I'm sure this is going to be an interesting one to begin with from that perspective.
So I'm the finisher last batsman, 11th man, and we need 12 runs in the 6 balls. So we'll try to win the match. So these all are the cases representing the importance of halting the puberty, whether it is early puberty or whether it is rapidly progressive puberty. So we know the HPG axis, it all starts with the brain. Hypothalamus will secrete GnRH, will act on the pituitary, gonadotropes, which will secrete LH episodes, they will act on gonad to produce the sex steroids. And this sex steroids will drive the puberty, estradiol in female and testosterone in male. But for the bone fusion in both genders, estrogen or estradiol is the hormone. Even in male, testosterone is converted to estradiol, and then this estradiol is responsible for the fusion of the bones. So criteria of the precocity, as discussed earlier, that in female, thelarche before 8 years and menarche before 9.5 years. And in male, any development either pubarche or testicular volume more than 4 ml before 9 years of age is suggestive of precocious puberty. So how do we diagnose the central precocious puberty? Because we are dealing with the GnRH, we will be focusing on central precocious puberty only. So clinical criteria includes it should be concordant puberty like thelarche followed by pubarche followed by menarche. Height spurt is again a clinical clue to the central precocious puberty. Now LH, basal LH is the newer guideline suggesting that now we have a more role of unstimulated LH, that is basal LH. And now they say that basal LH more than 0.2. So any detectable LH is suggestive of onset of puberty. Plus, we can do stimulation test if we are not matching the LH with the clinical parameters. Suppose if we have more pubertal features and still LH is low, and we are thinking of a properly central precocious puberty, then we can do GnRH stimulation test. Otherwise, the newer guidelines which were published in 2019, in which Dr. Anurag sir represented our ISPE, suggests clearly that nowadays basal LH of more than 0.2 you can take as origin or the onset of puberty. Of course, there is a role of ultrasound, but that will only supportive role like ovarian volume of more than 2 ml or uterine length of more than 3.5 mm, again suggestive of estrogen exposure and the onset of the puberty. Now, why do we need to treat the precocious puberty? Because there might be some multi-system affection which is driving the puberty, like tumor and all. So definitely we would like to treat that primary etiology which can affect the multiple system and not the only pubertal part. Of course, height is a major issue because we know that the high estrogen will initially lead to growth spurt followed by the early fusion. So ultimately final height will be low. And the psychological issues regarding the handling menstrual period at a very early age, when all the school friends don't get menarche. So treatment protocol includes GnRH. Now we are more focusing on depot preparation. So as compared to the monthly GnRH, now we are more preferring 12 weekly or maybe 24 weekly or maybe yearly depot subcutaneous infusion. The subcutaneous implant which is there, and any girl who has the feature of puberty less than 7 years and any boy who has the feature of puberty less than 9 years, at first visit, if they are of SMR3, then directly we can straight away start the GnRH analog on first visit. That is the new guidelines. If boy is more than 9 years and girl is more than 7 years with SMR stage 2, they have just onset of puberty, then they say then you can wait for 4 to 6 months to see the progress of puberty, because these all might be slowly progressive puberty. So there is no need for hormonal evaluation after 7 and 9 years of age in girls and boys. You can definitely wait, but if they are smaller than that, they are younger than that, then definitely they warrant the investigation at first visit and preferably treatment at the first visit. If there is systemic disorder which is driving the puberty like hypothyroidism and any other thing, then no hormonal treatment is needed. We should start the specific treatment for the disorder. Now we have triptorelin available, which can be given monthly, that is 3.75 milligram intramuscular, But most commonly used is the Leuprolide because it is freely available. In my city, we don't have triptorelin. So I'm using Leuprolide. Leuprolide can be given monthly or 3 monthly. It comes in 3 concentration in India, 3.75, 11.25 and 22.5. So either we can give 3.75 monthly or every 12 weekly, either 11.25 or 22.5 milligram. Or hysterine, which comes as 50 milligram of implant. You need a minor surgical procedure to put the hysterine implant. But in India, this implant is not available. In foreign, they are using because they just have to do once a year procedure. It will gradually release 60 microgram of hysterine per day, and then we will have puberty which is suppressed. So nowadays, this is the recent guidelines. Nowadays is initially when I was in fellowship, we used to give deep intramuscular because this this injection clogged soon after dissolve. But nowadays they are more preferring subcutaneous. So now you can give even subcutaneous. It will cause less pain. So initial swelling will be there, but it will quickly get absorbed. So nowadays they recommend more subcutaneous injection. Now they said that they prefer more of a depot, more of a 3 monthly, maybe 24 weekly, which might come in the future. And there is no weight-based dosing. Earlier, when we were studying, we used to give less than 30 kg and more than 30 kg. But nowadays, they say that you start with fixed dose, say maybe 11.25 milligram of Leuprolide, and then you monitor for the pubertal suppression clinical features, and then you can readjust the dose accordingly. So no weight-based dosing for this recent guideline, and of course, citrulline is not available in India. So what will this GnRH do? Breast size will be remaining stable, or they might regress the gland part. Of course, fat part will be there. So breast will not be going flat at all. Pubic hair and axillary hairs, because they are mediated by the adrenal gland, they will continue to grow. So many times it happens that the parents complain that pubic and axillary hairs are growing, but we should reassure them this will not affect the height potential of the child. Menses stops usually after 2 months of therapy. The girl can have breakthrough bleeding maybe once or twice after giving first injection, but definitely after giving second injection, menses should be stopped. If girl is still experiencing menstrual bleeding, then definitely her puberty is not suppressed, and we should look into the revising the dose of the GnRH analog. And hormonal suppression will be achieved after few months, after 4 to 6 months. So many times it happens that we tend to do LH after giving injection after first and second injection, but nowadays they don't recommend biochemical monitoring of doing LH maybe 2 hours after injections because hormonal suppression will take time. Before that, growth velocity, breast size and all are good clinical markers which can be used to monitor the therapy. What are the adverse effects after giving first dose? If the endometrial thickness is more than 5 mm, girl can have withdrawal bleeding for maybe once or twice. She may experience hot flushes and seizures has been noted in CP child whom because CP child, this GnRH analog will decrease the threshold for conversions. Weight gain has been noted, but still that is the normal weight gain of the pubertal spurt and all. No specific weight gain is associated with GnRH injection. Future risk of PCOD, it is not proven, and pituitary apoplexy can be there if there is GnRH hyperplasia and we give GnRH analog. So there will be pituitary apoplexy and we should be managing it as an emergency. How to monitor therapy? Clinically, we should be calling them 3 months. We should be checking for breast changes, bone age and growth velocity. Biochemical is a very limited role, but if at all you want to prove that the puberty is suppressed, post GnRH, post 2 hours of LH should be less than 4, and this you call as adequate suppression. Stop. When do you want to stop? So there is no fixed parameter. It depends on patient to patient basis. But overall, 12.5 years of bone age in girls and 14 years of bone age in boys is the clinical parameter, or we can say radiological parameter when we stop the GnRH. Other uses, particularly, they are officially recommended in transgender. In transgender male who have been converted from female to male, we can give this GnRH analog so that they can suppress the estrogen, and by giving 1 to 2 testosterone, they will have normal effect of the testosterone. But in female, transgender female, the testo will not be suppressed for initial period, so they might need for longer period this GnRH. But other, along with the growth hormone, because in some desperate families, in desperate some kids, they want to grow and they have achieved advanced pubertal progression, in which some centers are giving GnRH analog to hold the puberty along with the growth hormone, though they are growth hormone sufficient. But again, this is a controversial thing because in a way we are suppressing the growth spurt by suppressing the gonadotropins and sex hormone, and we are giving growth hormone in other way. So the height gain is controversial. So this is not a routine practice, and it is not recommended in fertility suppression, SGA, autism, or any psychological issues. So apart from this puberty, only transgender is the only indication in which we can use the GnRH analog. So learning point for this guideline is no weight based, more of a depot use, more of a subcutaneous route, use of unstimulated LH in the diagnosis, and less hormonal monitoring and more of a biochemical, more of a clinical as well as radiological monitoring. So I think I'm finishing rapidly. Thank you.
Thank you. So very nicely covered in such a small time, such a large topic, and I'd like to thank all of you for being here till this time. For the last 5 days, we have been running program for those who are on site. We are going to finish. I'd like to ask Dr. Hemchand to kindly hand over a moment to Dr. Vijay, who has been integral part of our programs. And with this, we'll be coming to the culmination of the program. I'd like to thank the entire support team from Regency as well as Growth Society, all the people, all the fellows who have been involved extensively in this, all the faculty who have come from across the regions, as well as all the pharmaceutical companies who have sponsored as part of this program, and all of you, the participants who have come from a long way to make this program a huge success. Thank you. We will have lunch in the 4th floor. The restaurant, the lunch is there. And so I think the lunch is ready and we can start from there. And because many people have a flight to catch or a train to catch, so maybe you can start lunch and then go in that regard. Thank you.